right there. So let's give Amanda a big round of applause for putting this together. So this has been a great journey for our center, and remember, we draw our inspiration from you. We learn from you. We love taking care of patients and providing interdisciplinary care and coordinating your care, and we learn what we need to be doing when we go back to the research lab from what you tell us. We don't dream it up. It doesn't come to us magically. It comes to us through the interactions. And so all the innovations and all the great things of all the researchers here and the clinicians and the interdisciplinary team, they happen because of you. And so we're very appreciative of you, and we believe that it's a partnership as we move forward on this journey, and we try to push the horizon of Parkinson's disease and to bring a brighter day and a better day.
And you may have noticed that I am not on the schedule to speak to you today. I know you're all tired of hearing me talk. The reason I'm here today is because our guest speaker is one of the world's most famous Parkinson's experts, and he's one of our mentors. And frankly, you don't get the opportunity to see someone like him speak very often. So I figured, if someone like him is speaking in my hometown, I'm going to go see what he has to say. He's just, Michael's going to introduce him, but the reason I'm here is to support, obviously, my colleagues and all of you, but mainly to hear Dr. Jankovic.
Great. So a couple of housekeeping tips. There's a feedback form that Amanda would like you to fill out. Remember, at the end of the day, there's also an Ask the Doctor session. We don't want anybody leaving here without their question answered. The entire staff is here this morning, and they're among you, so feel free to grab people, ask questions. This is all about interaction. There's a new Gainesville Young Onset Support Group meeting on the second Monday, and so if you're interested in that, at 6:30 is their meeting time. I hope that's 6:30 p.m. and not 6:30 a.m. And Amanda will tell you about that. And after Dr. Jankovic's talk, we're going to take questions immediately after that talk. So as your questions come up, I want you to scratch them on a piece of paper and raise your hand, and we'll come get them during the talk, and we'll feed them to Dr. Jankovic, and he'll answer as many questions as possible because he'll be leaving after his talk this morning. So with that, I would like to welcome our guest speaker for the symposium. He is the Stockdale Endowed Speaker as part of the Stockdale series. He has been here with us for several days. He has actually spent the entire day yesterday with our fellows and our residents in training, teaching them about Parkinson's disease. He lectured for 5 hours straight, and yesterday, which was amazing. He didn't even get up to go to the bathroom, which tells you what kind of, this guy's got a prostate of steel. And it was unbelievable. But it's so important that we pass the tradition down, that we're training the next generation. And so part of the Stockdale lecture series is to educate our future. And so we brought all of our residents and all of our fellows in training. So there were actually 30 of them that are all training to be grown-up neurologists and hopefully take care of the next generation of Parkinson's disease. Dr. Jankovic, I always joke with him that there's no living person in Parkinson and movement disorders that's published more papers than Dr. Jankovic, and I always say you got to keep living, Joe, because the tradition continues to go. He's a young man, and he continues to be the most productive and prolific person in the field, and he has made many important discoveries, been parts of many discoveries that span a wide range of topics, from genetics to pathophysiology, to attempts at cures and attempts at better symptomatic treatments, to the development of better symptomatic treatments. He trained at Columbia University in New York. He went to Houston, Texas, to Baylor, over 30 years ago, and they had nothing when he came to Baylor, and now they're one of the world's finest groups, and they have the largest Parkinson's support group in the country. It's called HAPS, and they're quite famous, and they raise a lot of money, and they put a lot of awareness into Parkinson's disease. He's an amazing advocate. He's been recognized with every major award in the field. And with that, I'd like to bring up Dr. Jankovic. And
way too generous. Well, thank you, Michael and Kelly, for the most generous introduction. Now that you learned about my bladder capacity, you heard everything there is to know about me then. So this is a real treat for me. I always enjoy talking to patients. As Michael pointed out, I come from Houston, and the Houston Area Parkinson's Society is considered the mother of all support groups. We have an annual meeting where we have about 500, 600 people attending, and each year they ask me to talk about different topics. But last year, which was their 40th anniversary, they asked me to cover the whole field. So I decided to come up with a list of 10 most frequently asked questions that patients ask me and other physicians ask. And what I hope to do is address some of these questions with you. And in some cases, I'm going to be more detailed. In other cases, but I'm going to show a lot of slides. And I don't want you to be frustrated by not being able to understand or read every word from every slide. To be perfectly honest, the slides are more to remind me what I'm supposed to talk about than necessarily for your benefit. But in each case, I'm going to try to highlight some of the points that I hope will be relevant to you and to your understanding of what Parkinson is all about and how we hope to treat it. So let me start with the first. I think I'm going to get wry neck from this. I'm not used to having the screen behind me, so you're going to have to somehow bear with me. I'm going to turn my back to you, which I don't like to do, but that's the only way I guess I can see my slides. So let's see if we can do this. Okay, and let's see if let me get everything organized here. I need 3 hands, actually. Okay, so here's the pointer, and I'm ready to go, I think. Am I okay? Yeah. Okay, can everybody hear me? Okay, so this is it? Okay. Okay, all right. So I hope you here on this side don't mind looking at my bald spot and my back, but that's the only thing I can do to see my slides, so please excuse me. So these are the 10 questions that I think are most frequently asked by patients and by other people interested in Parkinson's disease. And I'm going to try to address these questions as we go along. Admittedly, very briefly, but again, try to make the points as relevant to you as possible. So let's start with the obvious question, what is Parkinson's disease? So these are the facts. After Alzheimer's disease, Parkinson is the most common neurodegenerative disease. It affects about 1.5 million people in the United States. 50,000 new cases are diagnosed every year. And it's going to be the most common neurodegenerative disease after Alzheimer's in the future. It's a costly disease, not only in terms of human suffering, but also financially it's very costly. It's estimated that about $33 billion are spent on the care of people with Parkinson's disease. Per patient, it's estimated it costs about $22,800 per year in medical expenses compared to people who don't have Parkinson's disease, who spend only $10,000 on their expenses. Obviously, support of Parkinson's disease related research is extremely critical for us to make advances in our understanding of Parkinson's disease and treatment. The NIH clearly plays an important role in this effort. Michael J. Fox Foundation is becoming probably the #1 organization to support Parkinson research, but National Parkinson Foundation is also playing an extremely important role. They raise about $10 million a year for Parkinson research and other Parkinson-related activities. So philanthropy is critical, obviously, for us to advance the understanding of the disease. And this is just my pitch for those of you who are interested in Parkinson research and supporting Parkinson research. Please be as generous as you can possibly be. So this is National Parkinson Foundation. They raise about $10 million a year. About 70% of it is directed to patient care, research, and other services. In fact, your host, Dr. Oken, is the medical director for the National Parkinson Foundation, and we are a center of excellence. He's here pictured actually in my office with Joyce Oberdorf, who's the president and CEO of National Parkinson Foundation. So we are very grateful to NPF for their support. Okay, so how is Parkinson's disease diagnosed? We don't have a blood test to make a diagnosis of Parkinson. It's based on the history and observation of clinical features. Most of the motor features of Parkinson can be grouped under the 4 cardinal signs of Parkinson. And we use the acronym TRAP to help us remember those 4 cardinal features. The tremor, rigidity, which means stiffness of muscles, akinesia, which refers to slowness of movement, and then partial instability, which basically refers to loss of balance. So these are some of the motor features of Parkinson, but there are many, many other motor features of Parkinson's disease. There are virtually dozens, if not hundreds, of motor features of Parkinson. More recently, just in the last 10 to 20 years, many researchers have sort of shifted their emphasis from these classic traditional motor features of Parkinson's disease to non-motor features of Parkinson, including behavioral, cognitive, sensory, autonomic type problems like orthostatic hypotension, low blood pressure, constipation, urinary and sexual dysfunction, sleep disorders. These are also features of Parkinson's disease that really have not been fully recognized until the last 10 to 20 years. Again, we don't have time to discuss all of those features, but it's important to recognize that Parkinson's disease is not just a motor disorder, but also a disorder that has a variety of non-motor features that may, in many ways, be more troublesome, more disabling than the motor features. And maybe during the Q&A, we'll address some of those features as we go along. Now, again, as I pointed out, there's no diagnostic test for Parkinson's disease, but we put together these 12 questions that we think are helpful in sort of establishing the diagnosis of Parkinson in patients who have never thought of having Parkinson. And we actually validated this questionnaire in our clinic, and the Michael J. Fox Foundation decided to actually put it on their website. So if you are interested in this questionnaire that we found as a useful screening tool for the diagnosis of Parkinson's disease, you may get on the Michael J. Fox website and find the questionnaire. Now, for a long time, Parkinson's disease was thought to be a sort of a uniform disease. It was first described by James Parkinson in 1817 when he observed 3 patients in his office and 3 other patients on the streets of London. And he described these classical features that I just noted for you. But we have recognized over the last several years that Parkinson's disease is not a uniform disease. There are many different subtypes of Parkinson's disease, and that's one of the things I've been interested in for a long time. And basically, about 20 years ago, we published a paper where we identified 2 major subtypes of Parkinson's disease. One is the tremor-dominant form of Parkinson's disease, which represents about 75% of all patients with Parkinson, where the initial symptom is tremor, the typical resting tremor, and then the tremor evolves to other features of Parkinson's disease. And then the other type of Parkinson's disease that we refer to as PIGD, or partial instability gait gait difficulty form of Parkinson's disease, the PIGD form of Parkinson, which represents about 25% of patients with Parkinson. It turns out that those two subtypes have a somewhat different natural history. They have a different progression. They are treated differently. For example, the tremor-dominant form of Parkinson's disease tends to progress at a slow rate and is more responsive to medications than the PIGD form of Parkinson, which tend to progress more rapidly. Patients with PIGD Parkinson are at a higher risk to develop a cognitive deficit and dementia, and they are more difficult to treat than the patients with the tremor-dominant form of Parkinson. This is just a reference from an article we published, I think last year, to describe those two subtypes and then also describe other subtypes that I don't have time to discuss. Now, again, getting back to answer the question how we diagnose Parkinson's disease, just over the last few years, a new tool has been developed and approved by the FDA, namely DAT scan. So this is a special kind of scan that allows us to image the dopamine system in the brain. I think all of you now know that in Parkinson's disease there's a deficiency of dopamine. One way to treat Parkinson would be to replace the dopamine with L-DOPA. But we also take this knowledge to develop tools that allows us to image the dopamine system in the brain. And this DAT scan, which was approved by the FDA a few years ago, helps us differentiate, for example, normal dopamine system compared to abnormal dopamine system. So you can see here in a normal brain, you see this normal density of the dopamine transporter, whereas here in patients with Parkinson's disease, there's a marked deficiency of the dopamine transporter. So this is a useful tool, particularly in patients who are in very early stages of Parkinson's disease, in whom we are not 100% sure they really have Parkinson. And also it helps us differentiate Parkinson's disease from this other condition called essential tremor. Those two conditions are frequently misdiagnosed, and even experienced neurologists sometimes have trouble differentiating essential tremor, which is a much more benign condition, manifested mainly by tremor, from Parkinson's disease. So this scan, the DAT scan, allows us to differentiate those two conditions, essential tremor and Parkinson's disease. We have been working on other kinds of imaging, and this is from a paper we published recently on the future of research in Parkinson's disease, where we show this new imaging that we think is even better than the DAT scan, again showing the normal density of the dopamine system in a healthy individual, and here in a patient with Parkinson's disease you can see the marked deficiency of the dopamine system. So these are some of the tools that we are beginning to use to help us confirm the diagnosis of Parkinson's disease, but we still don't have a specific diagnostic test to establish the diagnosis. Now, there are a number of what's called biomarkers that are currently being tested to see if those biomarkers can also help us with the diagnosis of Parkinson's disease. And I'm not going to go into a great deal of discussion about biomarkers, but I just want to draw attention to this study called PPMI. How many of you have heard of PPMI? Okay, so this is actually a very important study funded through the Michael J. Fox Foundation. We participate in it where we take individuals in very early stages of Parkinson's disease and then follow them for at least 5 years. And then we test their blood, their spinal fluid, their genes, do brain scans, do all these diagnostic tests to see if we can find certain markers like certain proteins, like for example alpha-synuclein that you may have heard about, certain genetic abnormalities, a number of other markers that may help us establish the diagnosis early, even perhaps before the onset of symptoms. So having a diagnostic test that will identify individuals from a general population who are at risk for developing Parkinson's disease would be an extremely important advance. Because if we eventually are going to develop neuroprotective therapy that will slow down the progression of the disease, This is the population that we want to target, the population that does not have the full syndrome of Parkinson's disease, but is just beginning to develop symptoms or maybe even just at risk for developing Parkinson before they develop symptoms. So this is the whole purpose for the biomarkers, the PPMI study. We're looking, for example, at genes like a LRRK2 gene, which is one of the more common genes that can cause Parkinson's disease. REM behavioral disorder is a sleep disorder that I'm sure many of you have experienced, where you act out your dreams during sleep. It turns out that this is a risk factor for Parkinson. So many people with Parkinson have RBD, REM behavioral disorder, several years or even decades before they develop symptoms. So we think that this is an important biomarker for Parkinson's disease. Olfaction deficit, this has been well recognized that people with Parkinson often lose smell even years or decades before the onset of symptoms. So these are just examples of some of the biomarkers that the PPMI is looking at. So for every patient that I diagnose in my clinic, I recognize that there are hundreds of individuals walking around perfectly normal who have not yet developed Parkinson but are at risk for developing Parkinson. And as I pointed out, it would be wonderful to be able to identify those individuals. So the diagnosis of Parkinson really represents just tip of the iceberg because under the iceberg there are many conditions that have not yet fully developed into a full Parkinson disease. So we talked about gene mutations, for example. So there are individuals who have gene mutations but don't have Parkinson's disease yet. But as you follow them, they may develop Parkinson. We talked about essential tremor, and even though I pointed out it's a different disease from Parkinson's disease, it turns out that a subset of patients with essential tremor actually do develop Parkinson's disease. Then there are these non-motor features. We talked about anosmia, which means loss of smell, constipation. There are many, many, many features of Parkinson that may be manifested even before we establish the diagnosis or before the patients begin to develop motor symptoms. And that's one of the main areas of research currently, is to identify these biomarkers. And I pointed out about PPMI, but there are many other studies that are looking at that. Okay, what causes Parkinson's disease? If I knew that, I would get a Nobel Prize. But there have been many, many attempts to understand what is the mechanism of cell death that results in a dopamine deficiency. So again, I don't have time to go into this in any detail, but the bottom line is that most of us who are involved in Parkinson's research believe that there is a complex interaction between genetic factors and environmental factors, which then results in gradual loss of neurons in the part of the brain called the substantia nigra, which is the part of the brain that contains these dopamine-producing neurons. And as a result of the death of these nigral neurons, the patients with Parkinson develop dopamine deficiency. How that happens is obviously something that we are intensely interested in and researching. So if you examine the brain of a patient with Parkinson's disease, you see two major pathological hallmarks. One is the loss of the pigment in this part of the brain called the substantia nigra. So the reason why it's called nigra, the word nigra means black, and the reason why this part of the brain called the midbrain, this part of the brain is black, or substantia nigra, is because these dopamine-producing cells also produce a pigment called melanin, which makes this area black. So here you see the normal midbrain, here you see the midbrain of a patient with Parkinson's disease, and there's a depigmentation of the substantia nigra. So this is one of the classic pathological hallmarks of Parkinson's disease. The other pathological hallmark is something that you cannot see with your naked eye, but you have to use a microscope, and that's called Lewy body. And you're going to hear a lot about Lewy bodies as you read about Parkinson's disease, maybe even perhaps during the course of the day. So this is a histological hallmark of Parkinson's disease that you can see under a microscope. So in order to make a definite diagnosis of Parkinson's disease, one has to have these pathological criteria. Of course, it's already too late. You obviously want to make the diagnosis long before you examine the brain. So again, in Parkinson's disease, there's a depigmentation of the substantia nigra. We see these Lewy bodies. And the other feature of the Parkinson brain is that there is an accumulation of this protein called alpha-synuclein. How many of you heard of alpha-synuclein? Okay, some of you have. This is an important protein to remember because it's a protein that accumulates and aggregates in the brains of patients with Parkinson's disease and causes damage. It's a toxic protein. And it not only causes damage in the area where it accumulates, but actually it transmits from one cell to another. In fact, the most recent understanding of Parkinson's disease is that the Parkinson's disease may not actually start in the brain, but may start actually in the gut, it may start in your heart, it may start somewhere outside of the brain, and then this protein, this alpha-synuclein, which accumulates in the gut or in the heart and other parts of your body, then is transmitted into the brain, and then it causes damage in the brain, initially in the lower part of the brain, and then it ascends to the upper part of the brain, the brainstem, and the rest of the brain. So it sort of spreads in a way that really has not been fully recognized until just in the last few years. So this is a very important observation. So one of the things that we obviously would like to do is to get rid of the alpha-synuclein protein, and I'm going to talk to you a little bit about it, what kind of strategies are being used to get rid of this alpha-synuclein. So what else can we do to slow down the progression of the disease other than getting rid of the alpha-synuclein before it accumulates? There are a number of studies that have looked at this, for example, neuroprotective type factors has been found, for example, people who smoke have a low risk of Parkinson. That is not a suggestion that you should start smoking. And caffeine also has been shown to be associated with a low risk of Parkinson, which is one reason why I have about 4 or 5 cups of coffee a day. Another factor that appears to slow down or prevent the progression of Parkinson is exercise. Many, many animal and human studies have shown that exercise prevents or slows progression of Parkinson's disease. So what is the natural history of Parkinson's disease? Let's talk a little bit about that. We talked about these symptoms that may occur even before the typical motor symptoms of Parkinson, the loss of smell, constipation, and so on. This is the preclinical stage, and then there's an early stage, and then there's a more advanced stage. So there's, again, the accumulation of this protein, alpha-synuclein, which then causes dysfunction of the nerve cells and eventual cell death. So we would like to intervene, obviously, as early as possible, even in the preclinical stage, to see if we can slow down the progression of the disease. So this is sort of the natural history of Parkinson's disease. There are genetic environmental factors that result in the loss of neurons, like in the olfactory neurons that mediates your smell, or other areas before patients begin to develop motor symptoms. Then many patients, of course, are started on some therapy. In many cases, L-DOPA is the treatment that is used in initial treatment. The patients then improve, and their symptoms often get much better. They may even melt away, they resolve, and we call this the honeymoon period. but unfortunately, like many honeymoons, this honeymoon doesn't last forever. Patients begin to develop problems. They develop levodopa-related complications. So what we do in the clinic, what Michael and I and other Parkinsonologists do in the clinic, we don't necessarily treat Parkinson's disease. We treat the complications of levodopa therapy. That's what we do most of the time, and we'll talk a little bit about that later. In addition to the motor symptoms, which fortunately do respond quite well to levodopa, patients begin to develop these non-motor symptoms like cognitive decline, dementia. We talked about the autonomic symptoms and a number of other symptoms that unfortunately don't respond well to dopaminergic therapy. And that is the major challenge in the treatment of Parkinson's disease, is not necessarily to treat these cardinal motor symptoms, but to treat the non-motor symptoms and the motor symptoms that don't respond to levodopa, and eventually the patients may die as a result of complications. So how can Parkinson's disease be prevented or slowed? How many of you know who Sergey Brin is? Okay, our AV guy knows who Sergey Brin is. But Sergey Brin is one of the most famous people in the world because he's a co-founder of Google. He's also one of the wealthiest people. I think he's ranked in top 10 of the wealthiest people in the world. And he happens to have a gene mutation that has a high risk for developing Parkinson's disease. It's called LRRK2 mutation. So here's an individual who's perfectly healthy. He's in his 30s. He knows that he has a very high risk for developing Parkinson's disease. So what did he do to find out what he can do to prevent the development of Parkinson's disease? Well, he obviously Googled everything he could, and he came up with a conclusion based on his Google search that the most important thing he can do is to exercise. And he, in fact, started a very aggressive exercise program. He's a swimmer and diver, and he felt that that was the best way he can prevent the progression of Parkinson's disease. So I had an honor to meet him and meet his mother here, who actually already has Parkinson's disease, and she's the one who passed on the gene from her to him and to his brother. I'm just pointing out, so here's probably one of the smartest people in the world, and based on access to all the information available to him, he concluded that exercise is the most important thing he can do to prevent the development of Parkinson's disease. So this is just a slide. Again, I don't expect you to read it, but it reminds me to talk about the importance of exercise. I think all of you are very familiar with it, and your neurologist, I'm sure, talks to you about the importance of exercise. But there are many very well-designed scientific studies that have clearly proven that exercise does do some good. So this is not just somebody telling you you should exercise. There's actually scientific evidence to prove that exercise not only helps you in terms of your condition, your cardiovascular system, but there's actually a way that exercise can build up trophic factors in the brains and may actually slow down the Parkinson's disease through this biochemical trophic mechanism. Now, until quite recently, most patients were advised to go for a walk or swim and the usual kind of exercise programs. But there's new science that clearly indicates that short, high-intensity exercise is more beneficial than you taking 2 or 3 hour walk. And there's a lot of evidence for that, and I just want to emphasize that point. This is just one study that was recently published that talked about the importance of high-intensity exercise. Tai Chi is another, it's not a really form of exercise, but it's, I guess, a relaxation technique that has been also shown scientifically to be beneficial in patients with Parkinson's disease. What can we do pharmacologically with medications? So one of the problems in Parkinson's disease is there is too much oxidation going on in the brains, which then cause further toxicity. So therefore, antioxidants have been tested to see if we can slow down the Parkinson's disease. in animal models and then in humans. There are 2 antioxidants that are currently available. One is the deprenyl, and the other one is rasagiline. These are drugs that we sometimes use in early stages of Parkinson's disease to see if we can use them as antioxidants in order to slow down the progression of disease. There are many other mechanisms that these drugs have besides serving as antioxidants. For example, rasagiline, which has been studied very intensely, has been shown that if introduced early, it can delay the need for levodopa. And this is from a study called Adagio study, which was published in New England Journal of Medicine. It's a very famous study. We were fortunate to participate in that study. And what we showed here is that the group of patients that was assigned to early start treatment with rasagiline 1 milligram, there was a reduction in the motor score. We call it UPDRS. This is a clinical rating scale that we use. So there was a significant reduction in the score because of the symptomatic benefit, but then the patients continued to progress. The patients who were assigned to delayed start, who were initially treated with placebo, they had a much more rapid progression, and after 72 weeks, you can see that those patients who started rasagiline early had a less disability than those patients who were in whom the medication was delayed. My pointer is not working anymore. Is there anyone who can help me? No pointer. Okay, I'll just try to describe the slides. So rasagiline, of course, because of this observation, was thought to be a drug that could possibly actually slow down the progression of the disease. But when we applied to the FDA for indication to give us an approval to sort of develop rasagiline as a disease-modifying therapy, FDA just didn't think there was enough data to approve the drug for that purpose. So currently, rasagiline is not approved as a disease-modifying therapy, but I think there's very solid evidence that it does delay the need for levodopa. So what are the best available medications to treat Parkinson's disease? Well, we just talked about rasagiline, and we talked about its potential for slowing down the progression of the disease. But it also provides symptomatic benefit. So many of you who were starting rasagiline early on may have noticed some improvement in your tremor or slowness of movement or other symptoms that you have. And the improvement may not be very robust, but probably is enough to provide at least mild symptomatic benefit, and it justifies the use of rasagiline, I think, in early stages of Parkinson patients who have relatively mild Parkinson. But it turns out that rasagiline, and this is from a study we just published where we showed that those patients treated with rasagiline had a significant reduction in all these various motor symptoms: tremor, slowness of movement, rigidity, and so on. Now, rasagiline also has been shown to be useful not only in patients in early stages of Parkinson, but also in patients who are already treated with levodopa. And here from one of the studies that we participated, we showed that if we use rasagiline, we can significantly reduce the off time. So the patients with Parkinson who take levodopa and fluctuate, who have the on time and the off time, when we add rasagiline to L-dopa, we can significantly reduce the off time. And another study conducted in Europe showed a very similar result. So rasagiline is not only helpful in early stages of Parkinson's disease, but also in patients treated with levodopa who have motor fluctuations. So how do we treat Parkinson? We talked about MAO inhibitors, such as deprenyl or rasagiline. In addition, there are other medications that are used. We know that we cannot use dopamine as a treatment, even though we know dopamine is deficient in Parkinson's disease, because dopamine doesn't get across the blood-brain barrier. So we use levodopa, which is a precursor of dopamine, and it readily crosses the blood-brain barrier, and it is then converted to dopamine in the brain. So how do we enhance the L-dopa treatment? Well, one way would be to block the metabolism of L-DOPA in the periphery. So L-DOPA is converted to dopamine and 3-O-methyl-DOPA. If we block the metabolism of L-DOPA by using dopa decarboxylase inhibitors, COMT inhibitors. You don't need to remember any of this. But these are drugs that are often combined with levodopa in order to improve the transmission of the levodopa into the brain. So we don't use it, we don't prescribe levodopa. All of you who are taking levodopa almost always are taking levodopa with carbidopa, the carbidopa-levodopa combination, often referred to as Sinemet, or you may also have it combined with catechol-O-methyltransferase inhibitor like entacapone in a form of Stalevo. So those are the combinations that most people use: levodopa, carbidopa, entacapone combinations. So that is one way that we can enhance the effects of levodopa. In the brain, if we block these enzymes that metabolize dopamine, like using selegiline or racegylene, one can also improve the dopamine transmission. We can also completely bypass this dopamine synthesizing step and stimulate the dopamine receptors directly using a class of drugs called dopamine agonists. Examples of that would be pramipexole, ropinirole, Nupro, or rotigotine. These are the drugs that we most frequently use as dopamine agonists to stimulate the dopamine receptors. Now, despite all our efforts, many patients gradually develop what's called motor fluctuations. So instead of having 6 to 8 hours of benefit at the beginning of the treatment, the benefit gradually shortens, and some patients derive only 1 or 2 hours of benefit after each dose of levodopa, and that's called wearing off effect. And many patients, in addition to shortening of their levodopa response, they develop abnormal involuntary movements called dyskinesias. And all of you, I think, are familiar with that. So this is what I try to illustrate on this slide, is that the therapeutic window gradually narrows, and after several years of treatment, patients either are on, and when they are on, they have dyskinesias, the abnormal involuntary movements, or they are off and have trouble rising from a chair, have trouble walking, and that is what we deal with in our Parkinson clinic. Patients who have these motor fluctuations, they have the choice to be either on with dyskinesias or off and unable to move. So we have tried to address the question, how do we improve that? It turns out that L-DOPA, even though it is clearly the most effective treatment we have for Parkinson's disease, does have these complications in terms of the motor fluctuations and dyskinesias. And in one of the studies, we showed that 16.5% of patients taking 600 milligrams of levodopa develop dyskinesias after only about 40 weeks of treatment. So even after a relatively short period of treatment, less than a year, 16% already had dyskinesia in this study where we followed the patients very carefully from the time we initiated levodopa therapy. So I just want to show you an example of somebody with dyskinesia. This is a classic sort of a stereotypic type involuntary movement that patients with dyskinesia have. And there are many examples of that. Now, let me show you another example. This is a patient who called me a week after I increased her Sinemet, and she said, my tremor is worse, and it just didn't make any sense. Sinemet improves tremor, it doesn't make it worse. So I had her come in the clinic, and this is the movement that she has. So to her, it looked like she had increased tremor, but to me, she had dyskinesia. Okay, and I'm using as an example how important it is to make these observations, and you need to really describe to your neurologist exactly what's happening. Preferably, even take a video with your iPhone and send it to him, or have the patient have actually the neurologist examine you, so you can look at this and say, oh, this is not increased tremor, this is dyskinesia. So what are the best strategies to treat and prevent levodopa-related complications? Well, first of all, we know what the risk factors are. The higher the dose, the longer the duration of treatment with levodopa, those are the risk factors. We also know that young onset Parkinson patients are at a much higher risk. So the younger the age of onset, the higher the risk for these motor fluctuations and dyskinesias. We know that there are certain genetic forms of Parkinson's disease that increase the risk of these fluctuations. So in those individuals in whom we know that there is a high risk for these motor fluctuations, we have to be extra careful. We try to delay the onset of levodopa therapy and use the smallest possible dosages. So there are now new treatments that have been developed, and I just want to say a few things about those treatments that are specifically designed to prolong the response to levodopa. One of them is a drug called Ritari. How many of you have heard of Ritari? Okay, actually relatively few. This is one of the more frequently asked questions. When are you going to put me on Ritari? Because this is a drug that was approved recently by FDA. It's a different formulation of levodopa that has a longer duration of action and could be very effective in patients who have these motor fluctuations. This is from a study recently published showing that patients on Ritari have longer response to levodopa, they have less off time. We talked about entacapone, which is in a form of Stalevo, that also prolongs the response to levodopa, and most of you are familiar with that. And then dopamine agonists, like I mentioned already, pramipexole, ropinirole, and rotigotine, these drugs also prolong the response to levodopa, but many of them have potential side effects. And one of the side effects, for example, of these drugs is that they cause edema, they cause psychiatric, edema means ankle swelling, psychiatric side effects, sleepiness. In this study, we showed that although patients who were initially treated with pramipexole had lower frequency of wearing off effect and dyskinesia, they had a higher frequency of edema and sleepiness, so you always have to weigh the advantages and disadvantages. There are new dopamine agonists that have a longer duration of action, like the ropinirole XL and pramipexole ER, and then rotigotine, which is a patch that can be used to administer the dopamine agonist continuously. There's new treatments that also are being developed, and you're going to be hearing about Duopa, which is another treatment that has been recently approved for patients who have motor fluctuations in order to prolong the response to levodopa. So these are some of the side effects of dopamine agonists, including low blood pressure, headaches, drowsiness, increased dyskinesia, and some other side effects. The older dopamine agonists like pergolide and bromocriptine have a much higher risk of these complications, and we rarely ever use those. One of the most feared side effects is ICD, impulse control disorder, including increased gambling, compulsive shopping, and hypersexuality. This is one of my patients that developed this compulsion to collect certain objects like axes and pipes. So their house is all filled with these. This is a letter from his wife. So he has growing fascination with collecting objects, a behavior that seems to have blossomed since he began dopaminergic medication. Examples include a collection of these axes. One patient developed hobbyism. He was never interested in Indian culture, but for some reason, when he was placed on levodopa, he began to be interested in American native Indian culture and started to make bows and arrows out of nowhere, so just a new hobby. In some cases, Parkinson patients actually develop new creativity, and we talked yesterday with Michael and others about how Parkinson patients found new talents when they are treated with medications. They become artists, and those of you who have been to to the clinic. I've seen the art that his Parkinson patients donated, partly as a result of creativity. I'm going to stop here because this was going to introduce the topic of DOPA, but I just found out this morning that you have a separate talk on DOPA, so I'm not going to say much more about it, and just want to allow enough time for Q&A. So thank you very much. I didn't have time to talk about experimental therapeutics and what's in the future, but I think you are mostly interested in knowing what is available right now, and I'm sure that sometime in the future we'll have an opportunity to talk about experimental therapeutics. I will bring my crystal ball next time and look into the crystal ball and tell you what's in the future. But thank you very much for your attention.
Okay, so now's the time to scribble your questions down. If you have a question, put your hand up, and Amanda will grab your question and bring it on forward up to the front here. We take questions on baseball, art, history, literature.
Not baseball.
Not baseball. Okay, I'll take the baseball. You can have all the rest. Okay. All right. So first question for you, Dr. Jankovic. How can my children learn if they're at risk for Parkinson's disease?
Even though I was talking a little bit about genetics of Parkinson's disease, I have to emphasize that only maybe 6 to 10% of patients with Parkinson's disease actually have a genetic form of Parkinson's disease. So if there's a strong family history and there are several members in your family that have Parkinson's disease, that obviously increases the suspicion that you might fall into this small group of patients with Parkinson that have genetic form of Parkinson. And you may talk to your neurologist about actually being tested for one of these genes. The most common one is the LRRK2 gene that I mentioned. There are a number of other genes that have been discovered, and these tests are now commercially available, but they really should not be used indiscriminately in everybody. So if there's a strong family history of Parkinson's disease and you have an early, young onset of Parkinson, I think that might be of interest to you to know whether you have a genetic form of Parkinson, and that would then also help you address the question, what is the risk that my children will develop Parkinson's? So just to give you an example, if you have a LRRK2 gene mutation, your children have maybe 20 to 30% chance of inheriting the same gene and developing Parkinson's disease. So you're going to have to obviously think about it, have a family discussion about it. We don't test children for these gene mutations. We test only adults. They have to be 18 years old or older. But there has to be a really, really good reason for you to do these genetic tests because it has lots of implications for, not only for the prognosis, but for insurance and lots of other things. So I would not take it lightly, even though 23andMe, I think, offers these tests fairly easily. So before you do any kind of genetic testing, make sure you understand why you're doing that and have a very detailed discussion with your neurologist about it before you actually order the test.
Okay, next question. I understand there's a new vaccination that's been tested in Austria on Parkinson's disease, attacking alpha-synuclein. Can you tell us what your thoughts are on that?
So this was one of the topics I was going to cover if I had a little bit more time, so I'm glad that somebody asked that question. So there's a company called Aferis that's doing a study in Vienna in patients with Parkinson's disease and another condition called multiple system atrophy, where immunologically there's an attempt to decrease the alpha-synuclein. We're doing a study currently with a company called Prothena, where we're using antibody against alpha-synuclein. We infuse these patients with this antibody in an attempt to reduce alpha-synuclein. So this study already had a preliminary result, which was published in a press release about a month ago, where the company reported that patients who were treated with this Prothena drug, the monoclonal antibody, had a significant reduction, like 90% reduction in alpha-synuclein in their blood. But that does not necessarily mean that the alpha-synuclein in the brain was also reduced. So I hope you'll invite me back in a couple of years, and I can give the results of our study to see what's happening with those patients.
So there are a lot of people that think that Parkinson is linked to inflammation, and this may be addressed by changing your diet. Do you make any suggestions to your patients about changing their diet and how that might affect their Parkinson?
So this is, again, one of the most frequently asked questions. What about my diet? I'll give you a very simple answer. There is absolutely no need for you to change your diet, except if you have these motor fluctuations. Your neurologist may tell you that you should keep your protein intake low with breakfast and lunch in order to prevent the competition between the protein and L-DOPA. But otherwise, there is no specific diet for Parkinson patients, despite what you think about and read about. And this is a very frequently asked question. There's no need for vitamins, natural supplements. There are billions and billions of dollars spent on all these vitamins, and they do absolutely nothing for patients with Parkinson's disease. Many of them have been tested in our clinic and other clinics. There's no evidence that vitamin E, for example, or vitamin D, or any of these vitamins do anything for Parkinson.
Dr. Jankovic, I understand that Parkinson's affects the eye muscles. Can you briefly tell us what are the common effects on the eyes that you see in patients in your clinic?
So there are many ophthalmological features of Parkinson's disease. Again, we don't have time to discuss it, but the most common one is what's referred to as convergence insufficiency. So if I read a newspaper, my eyes come in like this, they converge. In patients with Parkinson's disease, they don't converge. So patients with Parkinson, they often say they have trouble reading paper. I often tell them, well, cover one eye or get an eye patch, and you can actually read better. So Parkinson's patients can actually read better with one eye than with both eyes. That is the most common ophthalmologic feature of Parkinson. But there are many, many others, and if you have problems with your vision, you really need to see an ophthalmologist, because just because you have Parkinson and you have trouble with your vision, it doesn't necessarily mean that the visual problem has anything to do with Parkinson.
Dr. Jankovic, we understand that you have one of the largest clinics in the country of Tourette syndrome as well as Parkinson. How often do you simultaneously see Parkinson and Tourette?
Well, yeah, one of my areas of interest besides Parkinson is Tourette syndrome. Tourette syndrome is a very common neurologic disease, usually starting in childhood, but may persist in adulthood, manifested by tics, blinking, facial grimacing, shoulder shrugging, sniffing, throat clearing, grunting. These are the motor tics. There's no evidence that Tourette syndrome, which is manifested by these tics, and Parkinson's disease are related. Both of them are relatively common, so it's not unusual for patients or families to have both conditions. But there's no direct relationship between Tourette and Parkinson.
One of my friends started the Nupro patch for Parkinson's disease and told me he almost died because of blood crystallization. Can you comment, is this real or is this myth?
I think what the question is probably referring to is a report about a few years ago, 3 or 4 years ago, when Nupro was manufactured in a certain plant and was found to crystallize. And as a result, the manufacturing had to be changed, and there was a 2 or 3 year period where we did not have Nupro. But it has to do with crystallization of the medication in the patch, not in the blood. Nupro does not crystallize as blood.
The new extended release of Parkinson medication, Ritari. I've been reading on the internet about many stories of switching over to this medication with complex Parkinson disease, where you have to take many frequent dosages every few hours, and the switch over is a disaster. What sorts of experience do you have in your clinic?
It's a challenge, no question about it. Ritari is a useful medication, patients with motor fluctuations, but the switch from Sinemet, carbidopa-levodopa, to Ritari can be very complicated. And you really need to work with your neurologist who is experienced in this switch from Sinemet to Ritari, because even neurologists generally don't know how to make that switch. And I'm not going to go through this mechanism, how it's done, but make sure that your neurologist is experienced in using Ritari and switching you from Sinemet to Ritari.
Are there any studies of high-dose steroids as a treatment for Parkinson's?
There probably are, but they are most likely going to be negative. There's no evidence that steroids do anything for patients with Parkinson's disease.
Okay. And last question from this morning. How much collaboration is there between the US, Europe, Australia, and Asia with reference to Parkinson research and funding?
Well, I always believe in collaboration, but it's challenging to have all these various geographic areas represented in a collaborative global effort. Certainly in the United States, there are many groups like the Parkinson Study Group and a number of other groups that work together for common cause and design clinical trials that eventually help patients with Parkinson's disease. Most of the new discoveries in terms of new drugs and new treatments are really driven not by academic institutions, but by industry. The drug companies develop the drug, and then they try to get together academic or private practice neurologists to collaborate in developing these trials and drugs. But there's very little collaboration, unfortunately, between the continents.
And my question for you, Dr. Jankovic, after doing this for 30 plus years, can you tell the group your level of enthusiasm about the new generation of developments coming from Parkinson? What's your enthusiasm?
Well, I'm by nature a very optimistic person, so obviously I'm biased. I think that the future for Parkinson patients is very bright. We are beginning to understand for the first time what the mechanism of neurodegeneration is in Parkinson's disease. We talked about alpha-synuclein, but there are many other mechanisms that are currently being studied, and I'm quite sure that eventually we're going to learn how to alter this mechanism that results in cell death. We talked about cutting down on alpha-synuclein as one strategy, but there are many, many other strategies that are being developed. We haven't even talked about surgery for Parkinson's disease, something that Dr. Oken and Dr. Foote are interested in. There are many new developments in surgical treatment of Parkinson's disease. So overall, I'm very, very optimistic. I think that bright for patients with there's light at the end of the tunnel for patients with Parkinson's disease. I think the future is very bright. Okay.
Thank you for coming. Let's put our hands together. Thank you. That was just terrific. That was amazing. Thank you. Thanks, Joe. So I have an encyclopedia of questions in my hands, so if I didn't get to your question, please don't panic. We have an Ask the Doctor session coming later, and these are going to be rolled into that session. So as you have questions after each session, put your hands up, give them to Amanda Eilers, and we're going to make sure that we get those back and get those answered. We want to shout out to Amanda, got a lot of support. We've got a couple of, put your hand up there in the back there. There's an orthostatic tremor drug that's supporting some of the events here today. There's the Stockdale Lectureship, which is presenting the events. Teva Pharmaceuticals, they donated some books that are on your tables, and so we hope that you enjoy those things and all of the great things that are provided at the symposium. And as part of the Stockdale series, there'll be a lunch provided for you too, which is the best part of the day, obviously. Our next speaker this morning is Terry Green, and many of you know Terry, and she is just an amazing force in Parkinson's disease research and in coordination, and is one of the leaders, if not the leader, from the nursing side of the lectern for understanding how we give duodopa. This is the new dopamine pump therapy. And it's complicated, it's complex, it can be done, but it needs a plan, and it's very important that as we think about these new strategies, we're thinking about how to best deliver them and to make sure that we have the caregivers, the nurses, and the entire interdisciplinary team aligned, and that we understand, who is best to receive the therapy, both short and long term. Nobody in the country has more experience in dealing with these patients and developing the educational materials for them. And so put your hands together and welcome Terry Green.
Thank you. Oh. Good morning. I am Terry Green, and I actually wanted to give you a little bit of a history. We started the clinical trial program at the University of Florida back in 2008. It really didn't get going until 2009, and I am happy to say that as of February 9th, 2015, AbbVie has been approved by the FDA to... I have to... Oh, okay. Has been approved for it to become commercial. Our site was very instrumental in doing the double-blind, which was very difficult for both our patients and our caregivers and the staff and everybody. But we've progressed on, and now our site will be probably one of the first that will be going and utilizing the commercial product. We've already transitioned 2 subjects to patients now, which has been really hard for me because they're like my babe chicks. And I want to make sure everything's good, but part of the whole process is making sure that we have done our job, and that is we train you on how to take care of yourself, you make sure your caregiver is well taken care of, and that processes are in place, as Dr. Oken was saying. So, sorry about, I have to read mine from the back too. Duopa is now called the internal suspension is indicated for the treatment of motor fluctuations in patients with advanced Parkinson's disease. Again, as we talked about it, I don't have a picture of the pump and the jejunum because that's proprietary still, but I will talk a little bit about that. It was, like I said, it was just approved February 9, 2015 to go from a clinical trial program to now being ordered by neurologists who have been trained by Duopa for their patients. And we are already getting requests for our GI surgeons to put in tubes for neurologists that have been trained outside of the University of Florida. Duopa is carbidopa and levodopa internal suspension. It comes in a cassette and is an infusion system is used to deliver the medication directly into the jejunum, which is in your small intestines, for 16 hours. That is what the clinical trial was all about, is that we had to have it for 16 hours. During the commercial program, it will be as long as you want it to be on, but technically the cassette is good for 16 hours. After that, it has breakdown, and it's not as effective. Each cassette contains about 100 milliliters of drug, and the PEG-J tube is placed by an experienced gastroenterologist physician done in a GI suite under fluoroscopy. I do know that there's some interventional radiologists that will be doing it. Our site chose that we would use GI doctors. I actually have the chief of endoscopy, of the GI suite, and the chief of endoscopy, who have been participating with us since 2008. And they have probably put in, between the PEG and the J, about 280. So they're pretty experienced at it. And the reason they've put in so many, you're probably thinking, well, we've only done 22 patients, is that the J has a tendency to want to move. We don't staple it in place, but we hope that it stays in place. And we've had patients that have never had a problem in their whole time of being on the clinical trial. Others, not so good. The weakest part of the program that I think is the connectors. The connectors are made in China. They break very easily. They come apart. So I change a lot of connectors. Duodopa requires a PEG-J for the proper drug delivery system. The placement of the PEG-J bypasses the stomach and is intended to avoid the effects of slowed and delayed gastric emptying. As most people know or don't know, is really Cinemet is absorbed in your lower intestines at a place called the ligament of Treitz. So we have the GI surgeon put that tube right to where the ligament of Treitz is, and I get a fluoro picture to make sure that it's there. As soon as I put that pump on and the patient is recovering, they're like ready to go. Because it's instantaneous. It's not waiting for a pill to bypass the stomach, the gastric juices, whatever you ate for dinner, and all those things. There's a specific pump that is given out, well, it's part of the program. It's called a CAD, Legacy 1400 pump, that is used to deliver the LCIG, or the Duopa, and will be programmed to be delivered individually for each patient. So what one subject may have or patient has is not what another subject's going to be. And what we have found is, and what I thought was really interesting, is that a Parkinson's patient is a Parkinson's patient. Now let me just tell you a little bit about it. I was told I would be working 20 hours a week. I don't think the first week I worked 20 hours a week. It's been 80 or 90 during the trial period. And the reason is that every Parkinson's patient is different. Everybody has their own different problems and issues that we had to resolve. So here I thought, oh, I've got this down pat. I didn't have a clue of what I didn't know. So we learn through all of our issues. I can still say that I can look at evaluate a Parkinson's patient for the commercial program now, and I will have to go through the same steps that I did when I went through the study, only because there are some patients that will not work. It will not work for you. And at the time during the study, the company wanted us to really get as many people in. Some people were not appropriate. And so it's the same thing as if you were going through a DBS process. The same thing's going to be happening when we do the Duopa process, because there's a lot involved, and what people don't remember is that you're carrying a pump, and the pump may not seem very heavy, and I'm going to show it to you, but if you're, in your 70s and you're carrying a pump around your neck for 16 hours a day, that thing will feel like you're carrying a 50-pound weight after a while. So we have different processes that we had to learn as we were going through this whole program. So the neurologist and the nursing staff will be working with the patient and the caregiver. And our site, I have to tell you, was one of the sites that mandated a caregiver had to be available. If you didn't have a caregiver, you were excluded. And the reason is that when you wake up in the morning, most of you are frozen, you can't get the connectors together. Who's going to do that for you? So we had to eliminate quite a few people because they didn't have a dedicated caregiver. You can't expect your neighbor to come over at 6 o'clock in the morning or 7 to put you on and then take you off at night and things like that. So now I do know that under the Duopa protocol, which is now the commercial, they are requiring a caregiver. So we've made some headway that it's very important to have someone there to support you. The neurologist will do a few things when he's looking at how to calculate the medicine. First is a morning dose, and it's like a large boost that you're given, and it's like a jolt. And that kind of gets you going because the pump is usually off from 10 o'clock or 11 o'clock at night till 6 in the morning. Because remember, we're looking at 16 hours, but people, they're going to adjust their day to whatever. So when you get up in the morning, you're going to want a jolt to get you going, and that's exactly what happens. You feel like, wow, and it only takes 10 to 15 minutes. It's not a 30, an hour and a half. It does not take long. So you'll have a morning dose, you'll have a continuous rate. So once the morning dose goes in, then the pump automatically goes to a continuous rate, and you have that for your 16 hours. It's just measuring how you're doing. And then there's another feature on the pump called the extra dose. The extra dose is like, you plan on going out dancing, okay? So if you're going to do that, you know that you're going to spend more energy. So you can give yourself an extra dose, which gives you more Cinemet, or the levodopa-carbidopa, so that you have that time frame, and it's delivered over about 4 to 5 minutes, and you have it. Or if you've eaten, I know that Dr. Jakovich mentioned about protein, but I have to tell you, one of the things we noticed in our program is the increase in protein throughout the day affected the absorption of the levodopa-carbidopa. Also, we found out lots of things, because our patients were the first group were in an enclosed area at the hospital for 10 days. So we had 10 very long days together for 18 hours to watch how they did. And we found one patient ate a bunch of chocolate almonds. I happened to step out of the room to make some orders and stuff, and when I came back, she was off. I said, "What did you do? Did the pump stop? What happened?" She says, "I ate some chocolate-covered almonds." And I said, "Well, how many? Like 5 or 6? She goes, "A can?" I said, "You can have 5 or 6, but you can't have the can." You have to think about that because it's protein. And she didn't think that chocolate and almonds would affect her, but it did. Other things that we really looked at, we talked about the vitamins and stuff. Our patients that we notice are very low in vitamin B6 and B12. And that affects also their homocysteine level, which I know that's a big thing, but we look at all the labs and all their vitamins, and we know that if you're low in vitamin B under this program, you're very fatigued, and you keep hitting the pump to help you. But the problem is that the pump can't do any more because your other body systems need to be helping you. So good diet is very good. Exercise is excellent. We encourage everyone to be doing that throughout the whole process. When we had them there for 10 days, we took them for walks. We went down to Wendy's. We had Frosties. We walked all over the place so we could see how they would react doing walking. We had patients that had been in wheelchairs and now were walking. So their strength and balance and gait and all was way off. So we had to have PT help us to go from a non-walking or in a wheelchair or using a walker to standing up straight or trying to stand up straight and walk with the pump. So we learned a lot about what we needed to do and what we did not need to be doing. The duodopa is continuously administered, like I said, over 16 hours. That is the goal of the program. The pump will be disconnected at the end of the 16-hour infusion. During the time off of the pump, the patient is allowed to take immediate release Cinemet, and some of our patients take, maybe a Cinemet. Well, what they do, which is real, we taught them this, and this is a secret, but you give yourself an extra dose, and then you're flushing your tube, which gives you another 60 milligrams of Cinemet, basically, and then between 12 and 4, they could give themselves extra Cinemet. And that was allowed. Well, now it's not a program. It's not a protocol. It's a program. So people are going to be doing whatever they want to do to make sure that they are on. People do not want to be off. That's the number one thing we found out. You don't want to be off, especially when you're out in public, when you're eating food, when you're with your friends or family or anything like that. Off was bad. And so we had to figure out a way to make it better. And so, again, we worked through a lot of processes. At the University of Florida, at the Center for Movement Disorder, we'll be implementing our program starting probably July 2015 with a multidisciplinary team, which means that for those who have gone through the DBS process, and you know you have to get with the PT and OT, and we're not doing neuropsych, but PT and OT is very important to us because if you're wearing a pump or you're having it around your waist, it throws your balance and gait off. So we are going to be implementing a process very similar to that because what we have found out is that if we don't, we are just giving you a pump and saying, go forth and conquer and hope you do well. That is not the intent of a program. A program wants to have positive effects. And we have had patients who've been on it for a long time. We've had patients that it just didn't work for them. Unfortunately, we've also had patients that have died, but it wasn't related to the pump. It was because of their Parkinson's. So, you know, when I look at the whole group of people that we've had since 2008, it's amazing to see the variety. I've had pediatricians, I've had truck drivers, I've had teachers, I've had marketing people, I've had a whole realm of people. I still have 2 patients, or subjects, because they're not patients yet, that still work. You know, they wanted to go back to work, or they were working and they needed to continue working, but the Parkinson's was in their way. So we really are trying to figure out how to transition, and I'm having probably the most difficult time, is transition our subjects that I've been very intent to being a patient that comes and sees our doctors or doctors in their community who've learned how to use this pump. So we will be doing the program, and we will be doing it from a multidisciplinary plan because to me, that's what we should have been always doing. We're also going to be looking at nutrition because nutrition is very important for us, especially with this pump. So let me show you the pump. The pump looks like this. This is the cassette. The cassette comes in a box of 7, and they must be refrigerated. This says not for human, but you know that's only because it's my testing. But this is the pump, and we give you this lovely, cheap, holder. But when you use it, when you put it in, it's so that you can see all the different buttons in it. And then this is the peg, Jay, that I was talking about. And the peg, somebody broke it on me, so I had to try and fix it. But this is the peg, this part here. This is what we call the bumper. So when they put the peg in, when the doctor puts the peg in, my GI, he puts the peg in through an endoscopy. You're asleep, you don't remember a thing. And this is on the inside of your abdomen. And what we want to have is like about 1 inch it back and forth to prevent what we call bumper syndrome. Everything that goes on with the program is discussed and detailed with the patient. So then they put this long tube, and this tube, which is a little curly thing, and it's called a freca tube, but my chief of endoscopy calls it the freca tube because he's never seen it before. He'll put this in the ligament of Treitz, and then we start infusing. And we put the pump on, and as soon as the pump is on, our patients are very happy when they wake up and say, I can move again. So the worst part about the pump program right now is this little piece right here, and that's our connectors. And they're made in China, and they break, they crack, they come apart, they do whatever they want. But we have already voiced our complaint many times to the sponsor and to now the company that they need to fix this part because when these break, the tube has a tendency to come out. And that's what we're trying to prevent. We want you to be able to be fully capable of doing whatever you want. The one thing that I like about the Duopa program, or as we call it, the Duodopa program, is that it goes into your stomach, okay? If you don't like it, it's not working, you can always remove it, but you have to give us 10 days, because if not, you're going to affect the abdominal wall. If it doesn't work for you, it's no big deal. 10 days, we're going to ask you to at least try for 2 weeks to make sure, but 10 days after they've put the peg in, we can take out the whole thing, and it will just heal up, and it will be a little red dot there for a while. So really, that's what that's the Duopa program that we're going to be implementing. And again, it's just another treatment for Parkinson's, and we have found great success. Our site had an FDA audit done last year, and we were very successful. Maybe because I'm really anal about a lot of things that I write down, what the patient says and all. But what they learned from our site that they didn't get from the other 2 sites that they also audited is that I write down what the caregivers are saying. I want to know, are they having problems? Because if they are, then we have to look at other alternatives. We need to find ways to help out. And so that's what we've been doing. And I'm very excited about it. Again, like I said, we're hoping to move forward in the summer or July of 2015. But we have a lot to finish up and get the patients that are currently as subjects rolled into the commercial. And once we get all that done, I already have like 4 or 5 names that I've already been given for me to be reviewing and seeing whether or not they want to be a candidate. Thank you very much.
Let's take a 15-minute break, get some food, get some drinks, use the restroom, and come on back and join us. Yeah, this is your chance to get some water and get up and go to the restroom. The restrooms are through this door, and then take 2 lefts. So now we're splitting into two different groups. Experienced people with Parkinson's is in this room, and Parkinson's 101 is in the room right across the hall. And that's for 2 talks. Then we're coming back together for lunch and for the Ask the Doctor.
So we're going to extend the break about 5 minutes just to let everybody have a chance to get drinks and food. But if you want to attend Meredith's physical therapy hot topics, you're going to stay in this room. If you are going to Parkinson's 101 and want to listen to Dr. De Jesus's medications in Parkinson's disease, go right across the hallway. Medications, exercise. Thank you. I'll do one more time. Okay, we're going to get this party started. So I would like to introduce our speaker in this room. This is, I was going to read the thing off. Hot Topics in Physical Therapy. And this is Meredith DeFranco.
I don't do well in heels.
Who normally doesn't wear heels. And I'll hand it over to her. Thank you.
Good morning, everybody. I know many people in this room, so what I wanted to talk about this year was something a little bit different. When we usually present to you all, we talk about physical therapy and occupational therapy and give you the 101 on what to expect out of your therapy team when you come to see us. But you all have been around the block. You know me, you know what I do for you and to you. I'm sorry. So this year I've asked a lot of our patients, everyone that I've been seeing throughout the past years, what did you all want to hear about? So this morning are some of the 5 hot topics that you all ask me about on a regular basis. There we go. Let's see if this works. Yeah, I gotcha. There we go. Most of you know me, but for those of you that do not, my name is Meredith DeFranco. I am a Gator. I went to the University of Florida for my undergraduate degree, and rightfully so, I majored in exercise. So it's not just because I like it, it's because I actually studied it. And then I got my graduate degree from Duke. Go Duke. Okay, we're still not moving. You might just have to toggle for me, Chuck. There we go. So I work on this team as well. We all know that our team is an integrative center. And I'm the physical therapist on the team, but the central portion of our team are you all, the patients. Therefore, our talk today is going to be what you requested. These are the answers to some of the questions that you all ask me on a regular basis. So today, our hot topics, we're going to be talking about funky feet, toe curling. I get a lot of you all that come and show me your funky feet. I do have answers for you for that. We're going to talk about the medical interventions for your feet, but then also some of the therapeutic interventions that you can utilize as well. Freezing of gait is a huge issue in Parkinson's. Fatigue, bowel and bladder issues. And lastly, of course, we're going to talk about exercise, but I'm not just going to tell you, you need to exercise. I think if I asked every single one of you in this room, do you need to exercise, you would say, yes, I know I need to exercise. But if I asked you why, the basic answer is because it's good for me. But I want to share with you the physiology, the science behind why the exercise is so good for you, what it's doing in your brain, what it's doing in your body so that you can be more empowered to stay compliant with the plans of care that we create and establish for you. Okay, so the first topic of discussion, toe curling, funky feet. How many of you all have funky feet? It's a good chunk of the room. Yeah, I know you got funky feet. So, what do we need to know about these funky feet? There is a big difference between an arthritic foot and a foot that has dystonia. So what is dystonia? Dystonia is these sustained muscle contractions. So throughout your body, you have muscles that are supposed to work in harmony. One is supposed to contract while the other muscle is supposed to relax. When that doesn't occur in dystonia, you get the muscles contracting at the same time, and your body pulls in different directions. Dystonia in Parkinson's causes focal dystonias. So sometimes you get it in your neck, that's the cervical dystonia, and when it's in your foot, it causes this toe curling. A lot of times this occurs when your medications aren't working well or you're wearing off your medications, and it's much more rare in patients that are not being treated properly for Parkinson's disease, which is not most of you all in this room because you are here and you are part of our team. Okay, so this is a very important point that I try to stress with the patients. There is a big difference between an arthritic foot and a dystonic foot. If you have a dystonic foot and you go to see your podiatrist or your orthopedic surgeon to treat your dystonia, you may not get the appropriate care for your foot. The main reason behind this, the source of your arthritis is in the actual joint itself, so it's localized to the foot. But if you go to your orthopedic surgeon to see if they're going to fix your dystonia, the cause of your dystonia is not coming localized from your foot, it's coming from your brain. So the options and the treatments that are available for arthritis, they provide medications, they do injections, and they also do surgeries. The cause of your dystonia coming from your brain, different medical interventions that they perform for dystonia. We have medications that we use. We make sure that your Parkinson's medications are better regulated, and then they also use the botulinum toxins, the Botox injections. But most importantly to know, when you have arthritis and they go ahead and say, you know what, your medications are not working, we're not managing the inflammation, surgery might be the best option. These surgeries can entail fusions, they can entail joint replacements. And for me, the most heartbreaking thing is if you have a dystonic foot and you get surgery on your dystonic toe, the worst thing that's going to happen is that you get a toe it's curled, they pin it, but then the source of the curling is coming from your brain. So you get surgery on a pinned toe, and it's going to continue to pull after you have surgery if your toe curling is because of your Parkinson's versus arthritis. So this is an important point for me to know and talk to you all about. And also because there's some pretty cool tricks that you can do to manage the toe curling that only take about 5 minutes. And our foot model that helped me with the videos that I'm going to show you, her toes were a little bit curled in the beginning, and after we did our physical therapy interventions on her feet, they were pretty straight and nice looking. Okay, so that's what we talked about, dystonia versus arthritis, big difference. So here are my foot remedies. These are the easy tricks that you can all use to help manage your funky feet. You can do all of them if you have about 10 to 15 minutes, or you can use some of them if you just want to take bits and pieces from the protocol that will help get your feet moving a little bit better. So, very first thing, we know that the dystonia is caused from muscle spasms, the muscle contracting. So you need to try to come up with ways to get your muscles to relax a little bit better. If you've got time, the first thing you can do for your funky feet, soak them in warm water. Warm water works very well to relax your muscles. Next, we're going to massage, then we're going to mobilize the joints. After we mobilize the joints, we're going to stretch them. We're also going to teach you it's a Pilates-based exercise, and then we are going to give your brain some feedback as to where your feet are in space. And then there are toe spreaders. I have another slide later on so you can see what the toe spreaders look like a little bit more in depth. And all of these things work pretty well to keep your feet from looking so funky. Okay, so first things first, you soak your feet in warm water. Second part, we've got a video of what the massage looks like. Now, if you've got the hip range of motion, you can perform the massage on yourself, or you can enlist your handy-dandy caregivers if they're willing and able to rub on your feet. So, first video on the left, this is massage. So the muscles that control your toes actually start high up in your calf. So you can do massage to any part of the back of your calf, all the way down into your plantar fascia. When you rub on that, your plantar fascia is on the sole of your feet. That helps to release those curling of your toes. And like I said, if you've got the hip range of motion, you can do self-massage. If you've got a partner, I can teach them how to rub on your feet as I am rubbing on our foot model's feet. If you are not so comfortable having somebody touch your feet, or your caregiver doesn't want to touch your feet, the video on the right, you can do self-massage with a tennis ball, a golf ball, and rub the plantar fascia. And that's an easy one. When you're sitting at night watching television, if your feet are bothering you, you can put the ball on the ground and just rub your feet. You can take a tennis ball or a golf ball with you anywhere. Because I get a lot of complaints that the toe curling really makes a big impact on gait. It can change how you walk, it can make you less apt to want to exercise, all of the above. Okay, so that's massage. First soak your feet, then rub your feet. Next, mobilize the joint. So the main thing with dystonia is you need to tell your brain where your body is in space, and you need to try to tell your brain how to get back control over your body to move in the appropriate manner. So mobilizing joints is to try to give feedback. So you kind of pull at the joint, you push the joint, and that helps stimulate the sensory receptors to release control over your toes. So I'm just kind of pulling and pushing on her toes. I'm spreading them apart. I'm just basically, your toes look a lot like your fingers. There's 3 joints in there, so you can do all at once. You can do one at a time, and that's joint mobilization. Next, you're going to stretch. You can stretch one toe at a time, you can stretch all of the toes at the time, however much time you want to spend. So I push them down. A lot of times you get that, your big toe that kind of sticks up here funky and won't go down. So if you pull it and hold, push it back and hold, you can get those muscles to relax. Now, the video on the right, this is a strengthening exercise for your feet. A lot of times if you go to therapy, they put the towel on the floor and they make you do the towel crunches. That's not my favorite exercise for your foot. If any of you are in flip-flops and you want to try this one, do it with me now. Okay, so natural tendency. When you point your foot, your toes also want to point. When you pull your foot back, your toes will open. To do some neuromuscular re-education of your foot, you want to do the opposite. So you're going to point your foot and try to open your toes, and then pull your foot back and curl them. So you do the opposite. It's hard. It takes some brain work. Ooh, I see she got it. She got it pretty good there. That's also a very easy exercise that you can do when you're sitting watching television at night. And this helps tell your brain and your foot how to work better together. Okay, so after you've got your toes nice and massaged, mobilized, stretched, toe spreaders. You can get these on the internet. You can buy these at the drugstore. They sell them. Females are more familiar with the toe spreaders because if you get a pedicure, these are what they put in between your toes so that the nail polish doesn't get ruined after you get your nails done. So they sell them at the drugstores for a pack of 10 for $2. You can sleep in them. A lot of times when you're sleeping at night, you're not taking medications at the regular intervals as you do during the day, so you're more off in the morning when you wake up and your toes can curl first thing in the morning because you have a little bit more stiffness and a little bit more rigidity. If you sleep in the toe spreader at night, it will help keep your toes spread. You can put the toe spreader on, put a little sock over top, and in the morning time, your toes will not be as cramped. Some patients like on the bottom, those 5-finger shoes, they make 5-finger socks. The shoes have different little differentiations so that each toe gets its own hole. And then they make silicone ones. Some patients even walk around in them. It's as much as your body can tolerate, but this is a cheap, easy trick that can keep you from getting surgery on your feet. And then lastly, like I said, these interventions, if you've got the hip range of motion when you're sitting down to cross your ankle over your opposite knee, you can do these on yourself. And you can see, so that's what our lovely foot model's foot looked like before we did the intervention, and then after. And mind you, we spent 3 minutes stretching her toes just so we could get videos for you all. And you can see how much straighter her toes are on the right-hand side versus the left-hand side. Thank you, foot model. You have a lovely foot. And there's the picture if you've got the hip range of motion, how you can do that on yourself if your caregiver doesn't want to rub on your feet. So some good tricks for toe curling. Come see me if that was a little bit too quick for you. I can help show you how to do that on your own. Next, freezing of gait. Freezing of gait is a hot topic, pun intended. Freezing of gait can be a huge impediment for your quality of life because it contributes to falls. What happens in freezing of gait? To be perfectly honest, we don't know the physiology behind why it happens. It happens to patients most of the time when they're more advanced in Parkinson's. It happens when your medications are wearing off. It happens when your medications aren't titrated properly. But also, it happens for unknown reasons. Things that contribute to freezing of gait, we know posture, decreased automaticity. What that means is we all know that the Parkinson's, when it takes over your body, it tries to get in the driver's seat. And it changes the things that we take for granted, such as when you walk, your arm doesn't swing as much on the side that you have more impairments. So the Parkinson's being in the driver's seat of your body makes it more difficult for you to do the things that automatically occur for the rest of us. And then impaired visual perception. This is a funky one, and we know that this contributes to freezing of gait because when you walk through doorways or when you come up into a crowded space or when you are walking and you change flooring from carpet to wood, sometimes that triggers the freezing. We apologize for the technical difficulties. We wanted to make sure we had the videos of the foot. Okay, so where does freezing occur? As I mentioned, it can happen when you change flooring, so carpet to tile, tile to wood, which is hazardous in your home if you've got carpet in your bedroom and then you've got tile in your bathroom and you get up in the middle of the night to use the bathroom and you freeze in the doorway, falls can occur doing that. Tight spaces, so if you have a smaller home and it's cluttered, that can trigger freezing and you have a hard time moving around in your home. Crowded environments. My patients that have trouble with freezing, when they go to the mall, it's a nightmare. Sometimes even when you get distracted. So we know multitasking with Parkinson's is very challenging. If you're walking and somebody talks to you, that can trigger a freeze and make it hard for you to move. But what can you do? Part of my role as a physical therapist is to try to figure out what's causing your freezing, what triggers your freezing worse than other things, and then what cues can make it better. The worst thing that you can do is to try to force through the freeze. When you force through your freeze, you actually make it worse. Frustration makes freezing worse. So the best thing when you anticipate or you feel that freezing coming on, you need to stop. Take a deep breath. And when I'm working with the patients that are freezing, I tell them, there's like a reset button on your forehead. You need to push the reset button, take a deep breath, and then try one of the following cues that we're going to talk about to see which ones work best for you. Now, what is it about cues? Well, we know that Parkinson's makes the automatic movements in your body not work as well as they used to. So when you throw a cue at the Parkinson's, we're trying to find a different route in your brain to facilitate movement. And these can be auditory cues, so sounds. These can be visual cues, different things that we can put around in your environment. These can be proprioceptive cues, which means different ways that we can move your body. And all of these tricks are things that we try to utilize to override the Parkinson's and use the parts of your brain that are still functioning very well. So, next slide should be talking about bypassing the basal ganglia. And this is a big thing that I try to empower the patients, especially those that have had it for a long time and they're frustrated and they say, well, this Parkinson's has just got a hold of me. And I say, no, there are ways that we're going to work around this. And this is what your therapy sessions are for, so that I can show you. The Parkinson's is only impairing one small part of your brain. We are going to try to find all of those pathways and those loops that are still firing very well, and we're going to override it and utilize. Your frontal lobe is one of the big ones that we use in freezing of gait, because we teach you how to show the Parkinson's who's boss by throwing all these cues at it. So attention cues. If you sit in our waiting room long enough, you'll see some of my patients using attention cues. This is one of the big ones where stop, think about it. So you're telling your body how you want it to move. Some patients like counting. So you'll see if you're sitting in the waiting room, 1, 2, 1, 2, right, left. A lot of the retired military men like the right, left, right, left. The one that I use a lot in therapy is stop, take a deep breath, and then reach for your heel. We know when you're freezing or you're festinating, you're much more on your forefoot, and you've got the short little shuffly steps. If you stop, take a deep breath, big step, reaching out with your heel, not only are you taking a longer step, but you're also, when you put your heel down first, you're activating those muscles in the front of your shins called your dorsiflexors, which pick up your toes. So you get a 2-for-1. You get a longer step, but then you also get your toes off the ground, so they're not dragging and shuffling as bad as they used to. So attention-based cues are the ones where you're using your frontal lobe and you're telling your body how you want it to move. If that doesn't work very well for you, we try visual cues. Visual cues can be like those walkers that you've seen. I don't think I saw a U-step walker in this room, but the U-step walker that's blue, he's got one, his is black. They have lasers on it. If you want to check out the U-step walker, I guarantee you he'll demonstrate it for you at our next break. That U-step walker actually comes with a laser. The engineer that constructed that U-step walker had a mother with Parkinson's who was a significant freezer, so that's where that walker specifically came from. The next thing, tape. I use chalk in the clinic to see if visual cues will work well for you, and then if it works well when we're doing a training session, I tell the patients, try some blue painter's tape throughout your home, and you can put either lines or X's wherever there's a place in your home where you freeze a lot. And I get women that tell me, I get in the closet, I try to find something to wear, but the closet is a tight space and it's really cluttered and they get stuck in the closet. So we teach them how to put visual cues all throughout their home. Now, the U-step walker, it's an expensive walker, and Medicare doesn't cover all of it. You need a letter of medical necessity from your doctor, and it also is very heavy, so it's very hard to get in and out of the car. So how I adapt the regular rollator walkers, there are some rollator walkers around in the room, my ghetto laser is that yellow TheraBand across the front of the walker. Your yellow TheraBand can act as your visual cue, and we train you how to, you push the walker out in front of you and you reach your foot underneath that yellow line, and you don't have to have a $700 U-step walker. It's the same principle. That's what the lasers and the TheraBands are used for. So attention, visual cues. Next are auditory cues. I think there's one slide before this one. Auditory cues are different sounds that we provide externally. So it can be me cueing you to say, big step, right, left, right, left. The other thing that is very easy, if you have a smartphone, we use metronomes. Metronomes are everywhere. You can even buy a metronome at a Radio Shack or at a Target or a Walmart. But what we know about the metronome, you need to set your cadence at a slower rate. When you're freezing and you're festinating, your body is moving faster than it needs to. So what we work on in therapy is turning it down. And when we put you at 80 beats per minute, that seems somewhere right around 80 beats per minute seems to be the sweet spot when you're working with a metronome. This is what we use in clinic. I've got an iPad, and we put a beat on, and we walk around the clinic to the beat. And it's a lot slower than you would usually walk, but when we slow you down, that enables you to take a longer stride length. And if we get a couple minutes at the end, I don't want to run over, I have a volunteer that will show you how to walk to the beat. Music. So if the metronome works well for you, we'll try the metronome when we're working together. You can also download, there are a lot of songs that have been specifically created to move at that same beat. So if you get really, I'm going crazy because I just hear this beat, 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 beat. There are songs that you can download and turn on music. You know, we know Parkinson's, it's a roller coaster. You have good days and bad days. Some days when your meds are working, everything's great, you can walk really well, you don't worry about it. But on a bad day, and the patient say, well, I was freezing so much, I didn't get out of the house, I didn't see anybody, I didn't do any exercise, you have a horrible day. Well, I say on your bad days, you need to find some of the music you like to listen to, blast that music in your home, and get up and keep moving. The worst thing that you can do is continue to sit, continue to get more stiff. You've got to get up and battle, and using music to help you move is one way to fight back to the Parkinson's. Proprioceptive. What does that long word mean? That means trying to move in an opposite direction. So the forward movement is what is hindered, the gait initiation, that first step is hard to get going when you have freezing of gait. So trying a different way to move your body to see if that helps. Dr. Haas did a study a couple years ago where he said, we're going to work on taking a backward step to initiate that forward step. It works really well if you don't have postural instability or retropulsion that causes you to fall backwards. So the backward step thing kind of makes me a little bit nervous, but we'll try it. You can also try rocking. Some patients like to sway side to side to get themselves to move forward. Some patients like to take a side step and even tapping. So, you know, if there's a leg that doesn't move, we talk to it. I don't hit it, we tap it gently and try to get it to hold up its end of the bargain and get you going. Companion dogs. I haven't worked with a lot of companion dogs, but I have seen some patients that, you know, just having the dog give a little tap on the side or give a little tug forward can help the patients unfreeze, so to speak. But the funky thing about cues that has been frustrating for me, I can teach a patient a cue, it doesn't work, and I say, I don't know why that didn't work, and then 6 months later it works. And then 6 months later it doesn't work again. So you can't give up on the cues. You've got to keep trying the cues. They're one size does not fit all, and they're funky. So in therapy, we revisit. The Parkinson's is weird. It changes every single day. But you've got an arsenal of all different types of cues, and this is something that we would work on together to try to keep you moving. So that's freezing of gait. Next, I think most importantly, of course, if we find a cue that works, you have to practice. The only way to preserve utilizing the functioning pathways in your brain is to practice, practice, practice. The best way to preserve your mobility is to practice. So if we find that moving to the metronome works well, you get that metronome, you go outside and you use the metronome to walk for exercise on a regular basis. The take-home point that you hear from us therapists all the time, use it or lose it, use it or lose it. We want to preserve your walking. Walking is one of the best things you can do to preserve your strength and your range of motion and your ability to swallow as well. Okay, technical difficulties. I apologize. I think we're talking about bowel and bladder next. I hope. Any questions while we're waiting for it to come back? Funky feet, freezing of gait? Does that make sense, what we talked about? Okay. Yeah. Bring it. I'll answer both. Go for it. Say again? It's like I paid you. Hold that thought. He asked me if silver sneakers helps walking. Oh, yeah. Absolutely. No, and this is, I know Lisa talked about this last year. If you get up and walk for 20 minutes in the morning and the rest of the day you sit and watch TV for 8 hours, that 20 minutes of walking in the morning is not going to be enough. I wish it was, but it's not. Okay, moving on. Oh, fatigue is next. I get this all the time from the patients. I'm so tired. My body is tired. I don't want to do your exercise program. If you can tell me how to fix why I'm so fatigued, maybe then I would do your exercise program. There are a lot of things in Parkinson's that contribute to fatigue. Mood changes. This is a big one that we screen for in clinic, and I encourage you and encourage your caregiver, if you are not yourself, you are not participating in your hobbies as much as you used to, if you just don't feel 100%, this is something that we can blame on the Parkinson's, and we need to treat it. You need to let your physician know if you are having changes to your mood, because if you are even slightly depressed or slightly apathetic, this whole therapy program, your wellness is not going to be easily managed, because if you don't feel like exercising, you're not going to exercise. And that is something we need to get treated for you. Next, the extra movements from Parkinson's. So the tremors, the dyskinesias, the rigidity, the changes to the activity in your muscles contributes to fatigue. You all are working harder to move every single day because your muscles are stiff. That is exhausting. So finding ways to manage your rigidity, your dyskinesias, making sure that you're taking your medications on time, making sure that you are stretching every single morning. If you are stiff and you are trying to get through your morning routine, it's going to be that much more exhausting. Few more. There we go, one more up. Next, motor fluctuations. If you are on, then you are off. If you are on, then you are off. This also contributes to fatigue, because we know when you're off, you can be more stiff. When you're on, you're wildly dyskinetic, and all of that causes to burning more energy. Sleep disturbances. We know Parkinson's makes it very difficult for you to sleep. If you have not brought that up with your doctor, you need to. If you are up in the middle of the night many times to go to the bathroom, that will disturb your sleep. If you are up because you are wearing off your medications at 3 o'clock in the morning, talk to your doctor. You might need an extra dose of medication in the middle of the night, or an extended release formula to keep you sleeping better. Okay, next. What can you do about this? Well, we need to figure out what's contributing to the fatigue. So I encourage you to make a log. When do you feel most tired? Is it in the afternoon? Is it associated with after you had a meal? Is it when your medications aren't working very well? What's contributing to it? And these are the things you want to bring ahead to your doctor. And then tips. What kind of things can you help to battle the fatigue? Exercise. This is very counterintuitive, and the patients complain to me, well, how can I exercise? I'm tired. I don't want to exercise. The exercise is going to make me more tired. Hang in there with me. When you are functioning at a lower level, your metabolism is kind of slowed down. Once you get exercising, it will boost your metabolism, and it will actually give you more energy. Next, you're allowed to nap. Naps are okay. I wouldn't nap for 2 or 3 hours in the afternoon, but if you need a 20 or 30-minute rejuvenating nap, that's okay. You're allowed to nap. Medications. Make sure you take your medications on time. If you are fluctuating throughout the day, you have on periods, you have off periods, that is going to contribute to fatigue. You all know, you have had Parkinson's for a while, you know the importance of taking your medications on time. Hydrate. You need to drink water. You need to eat well. Eating more fiber, keeping your bowels moving properly, which is what we're going to talk about next, will help you with your fatigue. If I know you all have a preference for sweets. If you are only eating a lot of sugar, you're going to crash at some point in time in the day, and that makes it hard. I see a lot of head nods out there. Try to balance out your sweets with something high in fiber and nutrition. Reduce constipation. Constipation contributes to fatigue because your bowels are expending a lot of energy to help function. Ask for help. This is something we need to know about. I ask the patients, oh, did you talk to your doctor about being fatigued? Well, no, I didn't think it was that big of a deal. I didn't know it was because of my Parkinson's. It is. Bring it up. Let's talk about it, find out why it's happening, and come up with something to treat it. And then conserve energy. Our occupational therapists spend a lot of time talking about energy conservation. So I stole these from Heather. Thanks, Heather. Pace yourself. You can't get it, if you have a very busy week ahead of you, you need to plan things incrementally. Don't run all of your errands on Monday morning. Try to spread it out throughout the day and throughout the week. Plan ahead. Schedule is important. If you know in the afternoon you crash at 3, don't plan 3 o'clock to be the time when you go grocery shopping. Plan when your medications are working better or when you know your body functions better. Simplify tasks. It's okay to use the equipment that we prescribe for you. It's to make your life easier. Sit when possible. This is a big one the occupational therapist will tell you. If bathing is exhausting, sit down so you have more energy to spend stretching or exercising. If you have a hard time balancing, staying upright to get dressed, sit down so that you're not fighting to stay upright. You sit, you get dressed, you stand up, you have more time and energy for exercise. Meal planning. So I know there's not a whole lot supporting changing your diet for Parkinson's, as Dr. Jankovic said, but a lot of times it's better to keep your engine more full throughout the day instead of having 3 big meals and your tank starts running on empty. I encourage the patients to snack, a mid-morning snack or a mid-afternoon snack. Constantly putting a little bit more fuel in the tank can help increase your energy levels. Okay, so we'll talk briefly about, I think I've got like 7 minutes left. Bowel and bladder issues. I'm not a pelvic health physical therapist, but this is a big issue that I want you to be aware of because there are things we can do to manage issues with your bowel and your bladder. Your pelvic floor. So the control of your bowel and your bladder, it's all musculature in your pelvis. That's a female pelvic anatomy, a male pelvic anatomy. And the strength of your pelvic floor, it acts like a sling, which helps control the function of your bladder and the function of your bowels. So different things that Parkinson's contributes to. Gastroparesis, the inability of your, food sits in your stomach longer, which you have slow movement throughout your bowels, which contributes to constipation. Difficulty voiding when you have the contents still in your bowel. Urinary dysfunction. This is a huge one that is a big hamper to quality of life. I have patients that are afraid to participate in extra activities because they have to go to the bathroom every hour on the hour. I have caregivers that don't sleep at night because they have to help their loved one up 6 or 7 times in the middle of the night because they're afraid they're going to fall when they get up to go to the bathroom. It's hard to exercise if you're afraid that your bladder is not going to be trustworthy. And one of the hardest things is the medications don't treat these issues. Your carbidopa-levodopa does not have a big impact on the function of your bowel or your bladder. So the things that patients can tell me mostly about when I talk to them about what are contributing factors to decline in your quality of life. Fall risk. Increased urinary frequency is definitely a fall risk because if you get up in the middle of the night, you're a little bit disoriented, you're trying to walk in the dark, you're not using your assistive device because it's not parked by the bed like I told it to be. And you have started avoiding activities. At this stage in the game, when your bladder or your bowels are not trustworthy, you have a harder time saying, sure, I'll go out to that support group meeting that's going to make me sit down for 6 hours straight, and I'm not going to be able to get up to go to the bathroom as much as I need to. There's probably some people that didn't come today because of this. Constipation. Constipation is defined as less than 3 bowel movements a week. I have patients that tell me it takes them 4 hours to get out of the house in the morning because they have to wait for their bowels to function. That's a huge impediment to the quality of your life. Poor absorption of medications. A lot of times patients say, well, I don't know why my meds aren't working. I took them as they told me to. Sometimes they work, sometimes they don't. It can be because your medications aren't being properly absorbed. Sexual dysfunction. Patients ask me about this all the time, and this is definitely something that has contributed a dysfunction of the Parkinson's disease. So what do we do about this? There are physical therapists that actually specialize in the health of your pelvis. They take extra education after school, and they treat you in all different ways, shapes, and forms, and they address all of these issues. They can do massage for your bowels. They do biofeedback. They do muscle strength training. They can treat the incontinence. They can treat pain. A lot of patients with low back pain, which I would say, some people say, oh, pain isn't part of Parkinson's. Oh, yeah, it is. And I would tell you probably about 9 out of 10 patients have low back pain. And some of it is because of pelvic floor dysfunction. What other kind of things could you expect if you have a consult with these types of therapists? So they do biofeedback. They have these cool machines. where you can actually see the function of your pelvic floor muscles on a screen while you're working with a therapist. And something that kind of will be mind-boggling for some of you, they do internal work. You know, they can palpate your pelvic floor muscles internally on men and females to tell if you're having the right sequencing of contractions, release of contractions, relaxation, if you have trigger points. It's pretty phenomenal what they do. It's not my area of specialties, but I screen for it and I help get you set up. We do have therapists in town that do specialize in this, and it can be a huge, huge game changer without having to add an extra medication. You know, a lot of patients say, well, I've been to the urologist, they gave me 3 more meds, this one makes me dizzy, this one makes me nauseous, and it's not helping that much. I'm going to the bathroom 5 times a night instead of 6 times a night. I encourage you to ask your doctor about consult with urology, ask them maybe if pelvic health might be useful for you, and then other things that the pelvic health therapists recommend to help improve some of these issues, making sure you're getting enough fiber in your diet, hydration, 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 to help with constipation. Bladder stimulants, this is a tough one. I'm telling you, you need to give up your caffeine and give up your alcohol because both of those stimulate your bladder and increase your incidence of incontinence. You know, the interesting thing also about incontinence and urinary frequency, a lot of it's behavioral. You know, a lot of people say, oh yeah, I go that one, before I came this morning, I did that just in case. Or every time I turn the water on, I know I feel like I have to go to the bathroom. The therapist would work through this with you because some of your behavioral learned things that we do throughout the day contribute to urinary frequency. Core strengthening, of course, exercise. So you can strengthen your pelvic floor, and strengthening your pelvic floor will help improve your control over these muscles and these functions in your body. Okay, of course, we saved the best for last. It's my favorite topic. So it's not just because I like to exercise, but it's proven. This is an important point. Inactivity will facilitate degeneration. Parkinson's is causing accelerated degeneration in all of you at a quicker rate. So what types of things does that contribute to? Well, if you sit around too much, you're going to feel more depressed. You're going to feel more apathetic. The density of your bones are going to decline. We know osteoporosis is more prevalent in patients with Parkinson's than your average compared community-dwelling elderly person. Constipation is worse. Yeah, if you sit around more, your bowels aren't going to be moving as much. Fatigue, it will actually make you feel more tired if you are resting more. Sleep disturbance, if you don't sleep well at night and you're not exercising during the day, it's much harder to regulate your sleep. But there is good news. If you exercise, these are some studies to document why exercise is so important, but exercise will actually help induce these growth factors, and the growth factors help with cognition, plasticity. Plasticity is that big word that we talk all about in therapy. Your brain is still plastic. Even as we age, your brain is still capable of learning. Your brain is still capable of changing. We want to use exercise to change it for the power of good versus the power of evil. When you're sedentary, that's the power of evil because all of these changes just accelerate when you are less active. So, we know inactivity facilitates degeneration, but what is the good news? What does exercise actually do? Prevents cardiovascular events. Parkinson's is not a killer for the most part. If we catch it early enough, we get you on a good program. Parkinson's disease itself does not contribute to diabetes, heart disease that most patients and most people in America die from. And when you are on a good program with your Parkinson's, it's going to keep you from adding an additional problem to your life, such as high blood pressure or heart disease. Slow bone loss, osteoporosis. This is a big one for me. When I see patients that are fall risks and we know that they may be at risk for having low bone mineral density, you need to exercise. We need to preserve your bone strength. We all know the worst case scenario is you fall, you break a hip, you end up in the hospital, and the hospital tries to kill you every time you are there. So, make your bones stronger. Keep them strong. Mood disturbances. Exercise helps your mood. The Parkinson's contributes to feeling like crud. If you exercise, you will feel better about yourself, and we will be able to manage the depression better than just with medications. Fatigue. We already talked about fatigue. Move it to keep yourself moving. Improve the movements of your bowels. Improve motor performance. Okay, so you all probably know most of that. But what does the actual science say? So this is my arguing point when patients say, well, I don't want to exercise. Why do I need to exercise? Well, here are just a list of some of the studies, but there are numerous studies showing that different things that can happen. Improved synapses. So we said your brain is plastic. Your brain is still able to be changed. If you exercise, you can improve how neurons talk to each other in your brain. That's pretty cool. Increase blood vessels, so increase perfusion. You can get more blood flow to your brain, which will help preserve the function of those neurons in your brain. Increase cell survival. We know Parkinson's contributes to cell death. Exercise so that your cells survive. Better remaining dopamine. I get a lot of patients that tell me that. When I exercise, I actually feel like my meds are working a little bit better. I'll take that. Lowers the risk for developing PD. That's a hot topic of discussion that patients ask me all the time. Well, I'm worried about my kids developing this. What should I do? What should I tell them? You know, what do you think I tell them? Tell your kids to exercise and eat right and not worry about it because we don't know if they're going to get it or not yet. Protects, so once you develop PD, I tell the patients the reason you need to exercise is because it's going to help delay the progression of the disease. So it will help decrease the degeneration. Improve the use of your medication, improves quality of life, decreases stiffness and bradykinesia. Well, that's a no-duh. I tell the patients, Parkinson's, it makes you stiff, achy, and shaky. What's one of the best things you can do to overcome the stiffness? Move. The first thing you get from me when you come to therapy is your morning stretching program. All right, how do you get started? Come see me. We'll talk about exercise. There is no one program that's best for everybody. Everybody needs an individualized program. Try a pedometer. Amanda has on her Fitbit. Just becoming more aware of how much you move throughout the day is huge. These apps are everywhere. You can download them for your smartphone. You can buy a pedometer at Walmart for very cheap. Exercise videos. If you don't like to go to a gym, you don't want to join a big group, do it at home. You can buy Tai Chi videos, yoga DVDs, do it in the privacy of your home, do it with your spouse, get a good laugh, because none of us are that coordinated anymore. Join a gym, YMCA, Silver Sneakers program, whatever it is that's going to get you going. How do you stay motivated? This is a big one. You need to have regular follow-ups with your PTs. I don't like to see the patients 1 time a year, 3 times a week for a month, and then not see them again until the next year. That's not enough to keep you motivated. The Parkinson's knocks you down. You need someone to help build you up on a regular basis, and it's too much to ask of your caregivers. So come see us. We should be your coach. We should be the one that is help keeping you going and rechange your program, modify your program, and make life easier for you. What other things are helpful? Workout partners, exercise groups, support groups, personal trainers. I don't mind working with a personal trainer. When I get a patient that comes to see me, your insurance doesn't cover your therapy as much as it used to, so I'll work with a trainer, help them outline a program, tell them don't go easy on the person just because they have Parkinson's. You actually need to go harder on them because they have Parkinson's. You're welcome. And lastly, set up rewards for yourself. I tell the patients, you get a Fitbit, you and your spouse have a competition, see who walks the most. At the end of the month, plan a trip, take a vacation, go out to have a nice dinner. I got one patient that she gets really motivated by Embers. Embers is her quarterly treat if she gets through her exercise program. It doesn't really matter what it is or how you get it, you just need to do it consistently, forever, and we can help. Thank you guys for having me. And we'll save questions for afterward. Sorry for all the technical difficulties. I'm not sure who's next, but if you want to stand up and stretch, I would fully support that.
So we're going to move into our next speaker, and if you want to go listen to the hospitalization talk in the classroom across the way, it has just started. You are welcome to go in. It's perfectly okay. And so I would like to introduce Dr. David Valancourt, who is going to be talking about tracking disease progression through MRIs and brain imaging. So. Sorry about that.
How's everybody doing? My name is David Valancourt, and I'm going to tell you a little bit about some of the research that we've been doing here at the University of Florida. So we're here in Gainesville, Florida. Last night I flew in on a flight from the Parkinson's Disease Foundation in New York. I was very privileged to be with Stan Fahn, who's a very famous neurologist. I come here and there's Joe Jankovic, and you have Michael Oken and Nick McFarland, all these other sort of very famous neurologists here. So it's very, very humbling for me to get to be here with you guys today. So we're here in Gainesville, and the University of Florida is here in Gainesville, and it's known for a lot of things. And one of the things that's really cool about the University of Florida is it's a very good university. It's right now, it's about the 14th ranked university in the U.S. and as far as public universities go. And you think about what is famous about the University of Florida. One thing that's famous is Gatorade, right? So everybody sort of recognizes the University of Florida for Gatorade. And there are also a lot of other cool things at the University of Florida that are also recognized at the university. And one of those is MRI. So not many of you might know, but there's what is called the High Field Magnet Lab, which basically is looking at research in tissues and also in vivo animals and also in humans, and developing new ways to look at MRIs in people so that we can sort of improve the way that diagnostics occur and also looking at new interventions. And so about 3.5 to 4 years ago, I was in Chicago, and it's freaking cold in Chicago. I don't know if you know that, but I moved here from Chicago, and we moved for sunshine. And I have 3 daughters, and those are there on the right, and they're very happy now that we live in Florida instead of in Chicago. So I want to answer one question for you. Why study the progression of Parkinson's disease? Why do we care about this? And I want to tell you that this is about the future, I think, of the way that medications will be tested in the future. And so right now, medications are tested on symptoms. They're tested, you give a drug, and about 60 minutes later, and many of you know this, you start feeling a little bit better and you start moving a little bit better, or the tremors get a little bit lower, or you turn the DBS off, or you turn it on, and you see performance change. But in many ways in the future, for Parkinson's disease, it's going to move to more of a model, I think, which is more similar to the way cancer is treated, to the way multiple sclerosis is treated, or the way cholesterol and heart disease is looked at. It's going to basically be using measurements of biology and testing a drug on that biological measure rather than testing it on symptoms. And you might ask, well, why do you care about this? Well, there's a great episode on 60 Minutes recently, which was looking at glioblastoma, which is a very devastating cancer of the brain. And this particular study, which is being performed at Duke University, is basically injecting the polio vaccine into the brain and injecting it right into the tumor. But the reason I think it's important for you guys, or for our own research, is because what they're looking at, they're not looking at the patient to see how the patient's doing. I mean, they are, but they're also looking at the MRI. And the MRI is telling them if the treatment is working or not. Okay, and that's really cool because that's very different from the way that we are doing it in the area of Parkinson's disease. And so basically they would look, and on the left there you would see the tumor, and then on the right is what is happening to the tumor only weeks after they injected the polio vaccine. And what they noticed in some of the individuals in the study, after a period of long-term treatment with the vaccine, the tumor is basically going away. And it's an amazing particular therapy. Whether it's going to work in a larger scale number of individuals is still a very open question, but it's a very interesting idea. And it basically suggests a way to sort of model looking at Parkinson's disease in the future. And so this is the way that MRIs are currently used in Parkinson's disease. You look at the image and you say, well, you don't have a stroke, you don't have a tumor, you're fine, you must have something else. And so there's nothing on it right now that tells you that you might have Parkinson's disease, or there's nothing on it that tells you that a drug might alter that particular image. So right now the MRI is really teasing out things rather than helping you identify something. And what I want to suggest to you is that might change in the future. Okay, so another example is cholesterol. So most people, a lot of Americans, are on cholesterol-lowering drugs, and the idea is you have a blood test, you check to see if you have a high cholesterol, and if you do, then you basically have a cholesterol-lowering drug. About 3 to 6 months later, you go back to the doctor, and they check your cholesterol, and it's hopefully a little bit better, right? And so that's another way that you measure a biological marker you test the drug on that biological marker rather than symptoms, because at point 1 and point 2, the patient looks the same in those particular instances. Whether you have high cholesterol or low cholesterol, you look the same. It's just that something in your body is doing a little bit better, and the medication is helping your body and basically preventing the risk of heart disease is basically what it's doing. And so the idea is to sort of move to a model like that in the area of Parkinson's disease. And so the area of the brain which is really important in Parkinson's disease is dopamine and the dopaminergic neurons, which are in an area called the substantia nigra. It's deep in the midbrain, deep in the brain, and basically that's an area of the brain that's producing a lot of the dopamine that is utilized, and is actually the lack of dopamine in Parkinson's disease is really what is a problem. And so most of the medications that are being used today are basically trying to sort of ramp up the dopamine that's available within the brain and help you move better. And so what we're trying to do is develop an MRI technique which might be able to visualize this in the human brain. Basically visualize changes in dopaminergic neurons or changes in the structural features around dopaminergic neurons as the progression of Parkinson's disease occurs. So we can track it, visualize it, and test new therapies on it. So John Lennon once told us all to imagine. And so the idea is to imagine what would this look like. Well, one way that it might look is to actually see the changes in the progression of this marker within the substantia nigra. And I'll tell you right now that I think we've developed a technique which actually can do at least partially this, or at least do a pretty good job of visualizing it. And so on the left is the sort of typical caricature of a progression of a person with Parkinson's disease. On the right is actual data. And so the blue that you see there on the two different images is the substantia nigra. And as that blue lights up more, that's basically showing you that what you have is an elevation of water content in that particular part of the brain. And I'm going to submit to you today that elevation of that water content may be indicative of changes going on in dopaminergic neurons within the substantia nigra. And that elevation of water content is actually probably not a good thing, and it may be something that we want to track and potentially try to treat in the future. Okay, so I'm going to try to tell you four things. I'm going to try to tell you first, what is accumulation of water content in the brain, and how are we measuring it? I'm going to try to give you a little sense of that. Second thing I'm going to do is tell you how it's affected in Parkinson's disease. The third thing I'm going to do is tell you how it changes with the progression of Parkinson's disease. And the fourth thing I want to do is share with you a study that we've done previously, which is the longest randomized clinical trial of a particular type of exercise intervention in Parkinson's disease. Okay? So first, what is sort of free water accumulation? What is this water accumulation that is occurring? And essentially what you see here is a bunch of different brain images. The one on the left is the typical type of MRI that is used by most radiologists today. It's called a T1 weighted image, and it basically means that it's weighted for a particular type of contrast. And you can't actually see things very well, and you can't see deep structures all that well in this image. You can see some things, but you can't see other things. And other types of MRIs, what is called diffusion MRI, which you see here in the colored ones, you can start seeing some of the features of the brain that you can't see on the other type of MRI. And basically what that allows you to do is it allows you to sort of look at the diffusion of water molecules within the brain and measure the diffusion of water molecules. And so if you look at the middle slide here, you see a bunch of cells, okay? Just a bunch of cells. And water is within those cells and outside of those cells. And the water can diffuse in different ways. And basically, as we think that as Parkinson's disease is getting worse and is progressing, the fluid content outside of those cells we think it might be increasing. And it might be increasing for a number of reasons. And basically what we're trying to do is measure the fluid content or the water content outside of the cells in a deep part of the brain that is really important for Parkinson's disease. Okay, so in the basal ganglia, you have called the substantia nigra, okay? And it has probably a little bit of elevation of free water or water content. And I've told you that, but now I'm going to try to convince you and show you the studies that actually show that, okay? So what we do is we take MRIs. It's a standard MRI. It's the standard 3 Tesla type MRI. It's a little confined. It's not much fun to be in, but it's a typical type of MRI that you would have in an academic hospital. And basically you lie there for about 10 minutes. And in that particular environment, you don't do anything. You're actually sort of looking at the structural features of the brain during that particular instance. And what we're basically doing in that instance is partitioning the amount of variance going on within a particular voxel in the brain and trying to assess how much water content is in there. And so what we find is, if you look at the upper left-hand corner of this slide, we find that people with Parkinson's disease have an elevation of water content in that particular part of the substantia nigra, which is really the part of the substantia nigra which has been shown in people who have passed away before, that's the part of the brain that's really the part of the brain that is losing dopaminergic neurons. So we're looking at the exact part of the brain that is really relevant to Parkinson's disease. So you might say, okay, that's all well and good, but does it relate to things that we care about, like how we move and how we think? And so the next slide basically shows you the relation between the water content, which is on the y-axis of all of these slides, on the left side, and on the bottom of the slides is cognition, which is on the left, and motor symptoms, which is on the right. And all the slide basically shows you is that the water content in the substantia nigra is related to how you think, and it's also related to how you move. Basically, the higher amount of water content, the worse off cognition is, and the higher amount of water content, the worse off your movements are. And so basically what that suggests is that it might be worth thinking about measuring that water content as people progress to see if it is changing as people progress through the course of Parkinson's disease. Okay, so another thing to think about is so that's just at the University of Florida. Well, what happens if you start measuring this at more than one MRI unit? And so there's Michael J. Fox Foundation has funded a very large initiative called the Parkinson's Progressive Marker Initiative, the PPMI. Okay, it's a very expensive project, and basically across many sites across the world, they're testing blood, they're testing spinal fluid, they're testing urine, they're testing brain MRIs, and they're trying to find markers of progression. And so what we did was we took their data and we asked the question, can we measure that free water in the data that they've acquired and see if we get the same finding? Okay, because if we do, then that means that we're able to replicate our finding at another study, and then that means that what we've measured actually might be a reliable marker. And so that's what we did, and the data here that you see, the upper left-hand corner, I know it looks like the University of Florida data, but it's actually the PPMI, Michael J. Fox data, and it basically shows you that there is a higher amount of that water content in the substantia nigra, very, very similar to what we found in the University of Florida data set. And so what that suggests is that part of the substantia nigra seems to have that elevation of free water, or that water content, and it may be very detrimental and very indicative of something that needs to be corrected. Okay, so now I want to tell you a little bit about the progression study that we've done to ask the question, does the water content in that part of the substantia nigra change as the progression of Parkinson's disease occurs? And if we were able to measure that, that would be very, very important, because then you can test new therapies or disease-modifying therapies to determine if it's altering the course of the way that the substantia nigra is changing over time, just like you can test to see if cholesterol or cholesterol-lowering drugs is altering the way cholesterol is changing over time. Okay? Because then you have a marker or a measurement that you can reliably evaluate therapies going forward. And so our lab is part of what is called the Parkinson's Disease Biomarker Program. It's funded by the federal government and the National Institutes of Health, and it's basically 11 different sites in the United States, all in different areas. And basically, we're sharing data with a lot of different groups. It's all de-identified. So people in our studies, you don't know, who it is when it gets shared. It's all sort of stripped of any identifiers. But the idea is that we're all working together as a big team trying to understand any sort of markers that might be relevant in the field, and so that we can also replicate them amongst each other. And so this is a very important initiative funded by the federal government to sort of study Parkinson's disease. And so what you see here in this graph is the healthy individuals. So we had a control group in this study of healthy people who don't have Parkinson's disease, and you can see that their water content and their substantia nigra is not changing with the progression or over 1 year of having the measurements taken. But when you look at the patients with Parkinson's disease, you can see the water content is going up in the substantia nigra just after 1 year, okay? And what that suggests is that we're able to reliably measure that water content in the substantia nigra, and it's likely indicative of something very important going on with the disease process. Now, the next thing that we asked was, can we predict, if we measure it at time point 1, can we predict changes in their motor functions after that, as that next year progresses, okay? Because that's a really important question. If you can predict what's going to happen to them physically the next year, then if you can alter what goes on at baseline, then you may be able to alter the course of that progression the next year. Okay? And so what this graph shows you is that either males and females, that the free water measurements that we had at the baseline measurement actually predicted how their physical movements occurred the next year. Okay? And so basically, the higher the free water content at baseline, the faster the rate of progression of their physical status got worse the next year. Okay? And so what this suggests is that we're actually able to predict the change in physical function after a year. And so you might ask the question, well, can you predict the change in cognitive function the next year, okay? Does this measure actually also relate to cognitive function? I showed you it did a little bit earlier cross-sectionally across individuals, but if you might want to also track it in the same individuals, okay? And in this particular study, it basically also relates to the cognitive status. So on the what is called the x-axis here in the middle, is the free water content in the substantia nigra, and it basically is related to how people were thinking or the quality of their thinking. And so as that free water measurement got higher, the rate of progression of their cognitive status got a little bit worse. Okay? And so what that suggests is that two things. One, when that water content in the substantia nigra is high, it seems to suggest that those people are going to maybe progress a little bit faster the next year, motorically or physically, and they're also going to progress a little bit faster the next year cognitive-wise. And so that seems to potentially be a good measurement, for evaluating new therapies in the future. Okay, so what can you do about it? So, you know, I've told you about things that might help people 10 to 15 years down the road. So you know, it's what can you do about it now? And I think Meredith sort of hit on this big time, okay? And one thing that you can do now is you can exercise now, okay? You can actually exercise. And so there's two ways there's a lot of different ways to exercise, but I'll tell you one way that I've seen and I think is the best, to me is the best data in the field, and it's a 2-year randomized clinical trial looking at resistance training and basically lifting weights, okay? And you should do this, you know, if you were ever to do this, you would want to do it with a therapist or with certainly a trained individual to help you sort of work through a program like this. And basically what we did was we took individuals with Parkinson's disease. We had 2 different groups, okay, and we followed them over a 2-year period of time. And basically they did 24 months of exercise. They were put into one group, which was basically a pamphlet, which is actually handed out by the National Parkinson's Foundation. So we use that, what is called Fitness Counts. We use that exercise program. And then we had a resistance training program, which is basically lifting weights. And it was a whole body program. So upper body, lower body, axial muscles, and basically had them sort of physically work out. And the reason we did this was because we have previously done studies and shown that when people produce high amounts of forces with their hands, that they actually activate and actually increase the blood flow to the parts of the brain that are affected in Parkinson's disease. So we had a real sort of biological rationale for looking at this training program. And so basically people did this 2 times a week, about 90 minutes per session. They did it with a trainer for the first 6 months to every 2 days, and then after that, the trainer showed up for 1 day a week. Okay, so there were 11 resistance training exercises that they did. They also did a little bit of stretching at the beginning, and then did all these different exercises. And it included, as I mentioned, upper body, axial, or sort of postural type muscles, and also your lower body muscles as well. And I just want to show you the data from that study, and then I'm gonna stop. So basically, this is really important. So on the x-axis is month. Okay, so 6, 12, 18, and 24 months. The y-axis is the clinical rating scale. Many of you probably do this. Is the UPDRS, which is basically the finger tapping, the hands back and forth, the walking, the standing up out of a chair, and basically it's that scale that measures all those different things. Okay, and the green up there is what is thought of a typical progression of Parkinson's disease. Just a few points on that scale a year is what is thought to occur. Okay? So the black that you see up here is the control group. It's actually what is called the Fitness Counts group. And what you can see is after about 6 months, that group got better. Okay? And then they went back to their baseline. All right? So basically they got a little bit better here, and then they went back to their baseline. But you can see they're still doing better than the green. Okay? Even though they're not doing what I would say is the better exercise program in this case, they're still doing better than what typical progression would look like. All right, so they're already still kind of beating the norm, if you will. And then if you look at the resistance training group, which is the red line here, they basically got better, and then they sustained that benefit over a 2-year period. Okay? And so they did much better than the control group, and they sustained that benefit. So they actually they basically controlled their symptoms for a very long period of time, okay? So 2 years is a very long period of time to sustain that benefit. And basically, if anybody is interested in this particular program, I can tell you about it, or I can share it with Meredith, and she can also tell you about it as well. So I just want to summarize. I've shown you a lot of different data, but I want to tell you that I've shown you 3 things, okay? One is that people with Parkinson's disease seem to have an elevation of water content in the substantia nigra, and that seems to be increasing with the progression over 1 year of the disease. And I suggest to you that that actually may be a good marker going forward of testing new therapies, okay? And if you take anything away from this talk, I want you to take away of why that's important. And it's important because it's a different way of basically testing therapies, similar to the way it's done in cancer, similar to the way it's done in MS, or similar to the way it's done in heart disease. And then the third thing I would just want you to take away is that this resistance training program, it's the longest exercise study out there. It was a randomized clinical trial, and it showed that one of the best efficacy for controlling symptom over a long period of time in people with PD. So I just want to thank people that work in our group. Our lab is funded by the federal government as well, the National Institutes of Health, so I want to thank them as well. Thank foundations that also support our work, and thank you all very much for your attention. I don't want to hold you from lunch. I think Amanda's going to come up and hopefully let you go to lunch now.
So the hospitalization talk is almost done, and it wouldn't be fair to just let you guys have the lunch and then the other guys come out and be like, hey, where's our lunch at? So I'm gonna hold off on like opening up lunch. Feel free to do, if you want coffee or the stuff on this end before the box lunches, go to the restroom, and in about 5 minutes, we'll open up lunch. So, talk amongst yourselves. If you want, the Aware and Care kits are in the far back table. If you haven't gotten a water bottle, please get a water bottle. I have some of the rainbow booklets back there as well. And if you have any questions, please let me know. Get your questions ready for Ask the Doctor if you haven't done so already. But yeah, 5 minutes and then we'll open up lunch. Thank you. If I can have our panelist speakers who need to come up to the Ask the Doctor table, come up to the Ask the Doctor table. Thank you. What? I got one. 1 in 7. I got a 1 in 7 chance here. 2's coming this way. 3's got a baby. You get your place of choice seating there, Dr. Hess. What's that? You get your choice place of seating there. Right here. Oh, the evaluations or the feedbacks? I have a box out front and I'll put it in there for you. Thank you very much. You guys are awesome. Thank you. Dr. McFarland. Oh. What's up? Oh. I made the announcement while you were in this year class. And also an announcement for the people standing in line at the tables, especially if you got to hear Dr. Almeida's talk on hospitalizations. The Aware and Care kits are available in the back of the room at the white and gold table back there. So if you would like an Aware and Care kit or need another Aware and Care kit from the National Parkinson's Foundation, please pick up another one back there. They're free. They're a gift to you from us and the National Parkinson's Foundation. Thank you.
Amanda? Yes. Do you have someone that you could spare volunteer to keep an eye on the baby doesn't wake up?
I'll keep an eye on the baby.
Otherwise, I can just bring a car seat over here, but
No.
it's kind of weird.
I'll keep an eye. I'm going to stand right back there with her. So
If she wakes up wiggling or jiggling, it's all good. It's like,
move in the little cart. Yeah, all good. Yeah. Dr. Valancourt, I'll be there with you.
Until last night, I showed it to my husband. He was like, "Oh, nice."
These are specific. are very specific where I think you couldn't really address them. These are all for you. They're either say your name. It's, patients can enroll directly in BMI. That's the question for them. Absolutely.
No, I'm laughing because you just look. Yeah, I think you're just kind of like a little ahead of me. They're all for you.
I know. Yeah. There's like we can group them. I can group this one. This one. And this one. Yeah. Here, we'll see if we got people. Is this working? Yeah, good. Anybody else have questions that they want to write down on papers? Just bring them on up. What's that? Yeah, or raise your hand, and looks like Amanda and her army in the back will pick them up.
Crumpling them up here so people can fall.
Oh, man. Yeah. Thanks, Bilal.
Look at this one. I don't know who's going to answer that one.
Who is the FTA? Who's the FDA? So drug administration. I can do that. I have one more question about something. Yeah, I'm going to combine. You know, like these are all. Accumulation.
These either one of us could answer. Okay. When will Rydery be available in the clinic?
There's another question about this one.
What is the state of gene therapy? These are all the ones that we can all compare, right? This is water.
This is probably something. Rewatered.
Okay.
Somebody asked.
Caffeine good or
Getting
bad?
water out of the brain. Yeah. Drink lots of water is not good for free water. Water's good for free.
Fragile and decreased oxygen is
Should we go? I think most people are sitting down.
That's interesting. They want to know is greater than a milligram basal any better?
Yeah.
Sadolene and less than.
We can put it right next to her.
Basically, I think they're trying to say lessens Alzheimer's. As opposed to 1 milligram a day. Is there any indication greater than 1 milligram per day is better? Okay, can everybody hear okay? We're going to go ahead and get started. If you have additional questions, you can wave your hand in the air and someone will come around and collect a piece of paper. We'll just try to we'll get through as many as we can. And you can send more up if you need to. Do you want to start with one?
Sure. Okay.
I guess we can, should we introduce ourselves?
So my name is Christopher Hess. I'm one of the movement disorders neurologists at the center, and I'm also a movement disorders neurologist at the VA in Gainesville. So if any of you have capability to be seen over there, that's always a possibility as well. So we'll go ahead and get started. So the first question, Rasagiline is known to decrease off time. Is dose still 1 milligram a day? Is there any indication for going higher than 1 milligram a day? So Azilect or Rasagiline, the dose is 1 milligram a day. The problem with going higher on the dose is as soon as you go above 1 milligram a day, the medication, which is an MAO-B or a monoamine oxidase B inhibitor, loses its specificity for the B receptor. It becomes a general MAO inhibitor, and it can actually be dangerous and interact with other medications. So in general, there should never be an indication to go above 1 milligram a day for Rasagiline.
I'm Irene Malati. I'm also one of the movement disorder neurologists. One question is caffeine good or bad? Is coffee or caffeine good or bad? So if you ask anyone on this panel, we'll say it's fantastic because we drink it every morning. But with regard to Parkinson's disease, it's been shown that an interesting epidemiological thing, which means when they look at risk factors and when they look at people with Parkinson's and say what could have made them more likely or less likely to get it, it turns out that coffee drinkers have a slightly less risk of Parkinson's than non-coffee drinkers, but it's not the case that if you have Parkinson's and you drink a whole bunch of coffee, it's gonna make you better. And we don't know what that link is. It's actually been studied. An interesting study looked at what about tea drinking? Is it the coffee or is it the caffeine? And it turned out that the tea also, the caffeine content, an equivalent caffeine content was also good. It appeared to be lowering the risk. And so nobody can explain if that's because other things that make you at risk of Parkinson's happen in people that aren't in a lifestyle drinking coffee, or is it the caffeine? We don't know, but it does appear to lower the risk.
I'll add one thing to that. So I'll add basically to this. So I'm Dr. McFarland also. So caffeine has action on a receptor in your brain called the adenosine receptor 2. So, and that's in the part of the brain that's affected by your Parkinson's disease. So there's plenty of research on caffeine. I will tell you that the research I know that's been done in this in animals tends to suggest the effects a little bit better in men than women, and we all know that men and women are different. But yeah, so caffeine is good, but we're not recommending drinking a pot of coffee a day, though.
And interestingly, they've even been studying a number of drugs that work on that particular receptor in the brain because of seeing that relationship with caffeine. So far in the small studies they look promising, and then in the big studies they haven't panned out, but it's still a possible target that's been looked at.
So we have one, I'll combine one. So we have one question on young onset Parkinson's disease versus older age Parkinson's disease. I think we do all up here feel that, you know, when young onset patients present, there are different challenges than when elderly folks. There is no one age. I mean, I guess we could say 65, 70 and above or below, but there is no one age. On average, onset of Parkinson's ranges. We see patients from age 30 to 80 years old or older who develop Parkinson's disease. Young onset patients present challenges in the sense that, you know, they're going to have Parkinson's disease for a much longer period of time. We may want to look into perhaps genetic or familial factors that are, you know, related to young onset Parkinson's disease as well. We have to think about sort of the types of drugs and treatments. You're going to be on these drugs for a much longer period of time. I think we had good talks today about the different drugs that are out there. For instance, the carbidopa, levodopa, the dopamine agonists. Which one to start? And that's a different question when we talk about patients who are a bit older. I think those of you who are probably in that older range, I think drugs, people tend to be more sensitive to the drugs and their side effects. And so sometimes less is more, and we aim for drugs that are a little bit better tolerated, like the carbidopa-levodopa over-agonists. But that's not a hard and fast rule, okay? Nothing in treating Parkinson's disease is ever black and white. We have the 50 shades of gray, no puns intended, but definitely there are definitely differences. The other question that was asked as part of it, do you progress faster when you're older versus young? Well, that's a hard question to answer necessarily. It's true that there are more complications if you're older. You have more health issues often that goes along with it, and of course, lifespan's shorter when you're older. So there are two things that play a role, but I would say yes, there are more challenges when you're older, but there are also different challenges for young onset Parkinson's. I hope that answered the questions for you guys. Yeah. I'm not sure that we have seen that yet, but that's a really good point in terms of environmental factors. We might see that yet, but we need more epidemiology to study, the onset of Parkinson's in the young versus older ages. That's a good point. Thanks.
All right, so I had a question here, which is a very good question. It says, we are encouraged to drink lots of water, but if the substantia nigra accumulates water, what do we do? Well, I'm drinking water. I strongly suggest that you keep drinking water. There is no relation between the amount of water you take and the measurements that are occurring on the MRI. So they're completely separate and unrelated. So you should definitely not stop drinking water. You should continue drinking water. Okay? It was a very, very good question that I did not expect.
Also another good one. My spouse has PD and is afraid of falling, is very stiff, and doesn't have bad tremors, which we know can be the case. You don't have to have tremors to have Parkinson's. My spouse hates exercise and frequently refuses to do it. I want to bring him to PT and want to get a personal trainer involved to force my spouse to do more exercise. What do I do? I sympathize with you. I'd say about 50 to 60% of the patients tell me they hate exercise. Encourage your spouse to give me one visit. One visit for me to show you that exercise doesn't mean I'm going to sign you up to run a marathon. It means I'm going to show you a way to make your body move better, to decrease the stiffness. That is a very easy one. On that first session, we can put you down on the mat, take you through a bunch of stretches, and I guarantee you your spouse will feel better after they leave and we've done 5 minutes of stretching. So just bring them to the door and I'll take care of the rest. And we will help find so if you don't want to call it exercise, we'll call it activity that will help modify the Parkinson's, and we will find something that we can convince your spouse to do.
The question I received is, what would prevent the pump being like an insulin pump, effused subcutaneously and absorbed into the blood, and therefore being less invasive, smaller and able to read, and greater than 16 hours? Actually, the company is looking at having a smaller pump. I've actually been part of the group looking at having one because we've complained that this is a very cumbersome pump and stuff to use. I don't know anything about it being subcutaneously because the tube has to be in the ligament of tripes where the gel is absorbed, and that is where cinnamon is absorbed. In terms of the 16 hours, that is because the cassette that holds the drug starts breaking down, and there's a byproduct of hydrazine, so you do not want that to be breaking down and going through your system. So we have lots of different things that we're trying to work out, but we are working on a smaller pump, and we are working on a more concentrated suspension that can go for longer than 16 hours. But right now, this is what the FDA approved, and so we can't do anything until we can move on to the next level. Thank you.
So there was a question on what our thoughts are on focused ultrasound. So in the past few years, there has been some research done on non-invasive mechanisms of making a lesion in the brain similar to the DBS that we do now, which is actually an electrode that's placed in the brain. The most important thing to realize with the focus ultrasound is that this is a destructive lesion, even though it doesn't involve opening the skull in the same way that a surgery does. And once this procedure is done, obviously it's very important that they have to get it in the right place, and that process has not been as well established and carefully carried out as it is for deep brain stimulation, and it can't be taken back. With your DBS, adjustments can be made, stimulation can be increased, decreased. Once the focus lesion is made with ultrasound, it's there and it can't be taken back. So it tends to be an option in some cases for some people who otherwise can't undergo DBS, but there's certainly no reason to think that it's in any way better than the standard deep brain stimulation.
Okay, this question says, how do you know if you're over-medicated with non-Parkinson drugs like sleep aids, antidepressants, anti-anxiety, etc., or am I just spacey for my Parkinson meds and my Parkinson's disease? So the question is, if you feel kind of spacey or dazed, how do you know what causes that? And basically, you kind of have to work with your treating practitioner to sort it out. It's true that Parkinson's can cause people to feel cloudy sometimes or fatigued. It also has an increased risk of sleep disorders. So sometimes disordered sleep causes, even though you spent the right amount of hours in bed, you may not be getting restful sleep. So there can be an excessive somnolence or sleepiness during the day. So looking into whether you could have a sleep disorder is number one. Number two is looking into whether there is a medication that's giving you side effects. All the medicines that treat, for instance, medicines that treat bladder problems that many people who have Parkinson's also may have, medicines that treat all these other things can cause sleepiness. And the best thing is look at the timeline when you first noticed it. Was a new medicine introduced? If not, you might have to work with your doc about stopping one at a time to see if that one of them makes a difference. But fatigue is probably one of the most common and challenging symptoms in Parkinson's, and it is very complicated. The question also included, how do I know it's not the Parkinson medication? And the biggest clue would be if the timing lines up. If you said, boy, half an hour after my pill, I feel really, really tired, then you might suggest there's a relationship. But it's always finding the balance between taking enough to control your symptoms and not overshooting.
I have a number of questions here about, I'm just going to lump them together basically about what is it, how do I know if I have something other than Parkinson's disease? So today we're focusing on Parkinson's disease in the symposium, and this is probably a longer talk. I won't spend a long time to answer it. But I will say I run an atypical Parkinson's or Parkinson's Plus clinic in the center, and there are a number of different disorders that mimic Parkinson's disease or look like Parkinson's disease. So it's not uncommon. Parkinson's disease tends to be the common thing that we see. There's nearly 1.5 million patients just in the United States who likely suffer from Parkinson's disease right now. Atypical Parkinson's disorders are much less frequent, of course, but they are very, quite devastating, just like Parkinson's disease. So what can you do? Well, I would suggest really there are sometimes red flags. For instance, I have Parkinson's, my drugs aren't really working, or they never really worked. Generally speaking, about 25–30% of Parkinson's patients don't really get a great response. But it is definitely something that if your medicines aren't working or never did work, that's what I would call a red flag. If you've never had tremor, now that's not a really, I think there's probably many of you who have Parkinson's disease and tremor's not really part of your disease. And I think you heard Dr. Joe Jankovic this morning talk about there are subtypes to Parkinson's disease. There is one type that we see as mostly postural instability, gait problems, where tremor is really not a predominant part of the disease. But if you've never had tremor, you have more symmetric symptoms or perhaps very asymmetric symptoms. That seems unusual. Or if your doctor, your neurologist says, look, my tremor, it's not the typical pill-rolling tremor that, my fellow Parkinson's or you see other folks in the room may have something different. There are certain red flags that may bring up the possibility that maybe I'm suffering from one of those diseases that may mimic Parkinson's disease. It's really our job as your neurologist to kind of think about these things and keep a broad perspective. And in fact, actually, our Parkinson's disease guidelines suggest that almost on a yearly basis that, you know, we as physicians kind of rethink things and make sure we keep an open mind about what's going on. So what are the possibilities? There are many drugs that you can take that can cause Parkinson's symptoms. I can give you a long list of different drugs. If you're on a psychiatric medication, antipsychotics can cause Parkinson's. There are a number of drugs like anti-nausea medicines, if you take those, can cause potentially what looks like Parkinson's disease. Stroke or vascular disease can cause symptoms like Parkinson's disease, and sometimes can be, you know, treated just like Parkinson's, but it's not Parkinson's disease. It's called vascular Parkinson's. And then there are a number of other more rare disorders that we see regularly in the clinic, things like progressive supranuclear palsy, multisystem atrophy, Lewy body dementia, or cortical basal. I probably would spend an hour or even longer talking about each one of these individually, but just know that we look for these when we examine our patients, and there are specific issues and problems. Generally, these patients do progress maybe a little bit faster, they have more complications, and they really require a comprehensive clinic. I think that, you know, we have that. We have some really great support folks in our clinic, you know, from the top down really, that can really help you. And if you think that you've got some red flags or just something's not working for you, you know, by all means ask, and we will go and, you know, and look more carefully and see whether we can do. There are things that we can do to help patients for all of these disorders. So, yeah.
So the next question that I got was, who is the FDA? Is it one person or a group of people? And then why are they so slow to make approval of new drugs? So the FDA is the Food and Drug Administration for medications or other types of therapies. They generally are there for licensing the marketing of the particular therapy. So if somebody said that they had a new drug that cured Parkinson's disease, they would have to go through the FDA, and the FDA would allow that licensing of that new therapy. And it's basically protecting all of you from going out and buying that thing that probably didn't work in the first place. So the FDA is there to protect people and help license things and market things the way they've been shown and proven to be marketed. The other thing they're there for is safety. So they're trying to make sure that things that go in people's bodies are safe and that they are okay for people to have. And so it takes a long time to get FDA approval and a lot of money to get FDA approval because they have a lot of hurdles and a lot of hoops that you have to jump through to get something through it. But it's there for a reason, and it's largely there to protect people. And it's also largely there to protect everybody's, economic interests. So, you have healthcare and a lot of things that pay for a lot of things that people use. And so you only want to use things that have been proven to work. And that's why the FDA is there.
And an important point is that the FDA does not regulate herbals and natural therapies and things that, sometimes look really interesting that are over the counter. You should be aware they're not regulated. So there's a difference there in what you can know has been reliably tested sometimes.
Okay, this one is in regard to the study that Dr. Valancourt talked about, and it says, with resistance exercise, you did a 90-minute program 2 times a week per session. Can you get the same results with 30-minute blocks 3 times a day, 2 times a week? Or do you have to do the 90 minutes in one setting? I think you could definitely get the same results if you split it up into more frequent sessions at a shorter duration. And honestly, for me, there are tons of studies supporting all different types of exercise for Parkinson's. The main point of all these studies, whenever you get on a consistent program that you do multiple times a week, you're going to get better. So if you like the big program, if you like Tai Chi, if you like yoga, if you like boxing, it's whatever we can find that you will like to do, that you will do consistently today, tomorrow, and forever, that's going to make the lasting changes.
I got a question. Could you talk about the foods and eating patterns you found most effective during your study? I know that Dr. Jakovich talked about proteins and vitamins and things like that were not as important from his standpoint, but what we found out from our study is that proteins did affect the absorption of the levodopa-carbidopa. Also, we monitored vitamins very carefully, or the specific levels, especially vitamin B6, vitamin B12, because what we found out is when their levels were very low, they were very fatigued. And I could give as much Cinemet as I needed to, but it didn't affect the outcome of the patient being less tired. So what we suggested and what we monitored during our study is that instead of having 3 main meals a day, that you had 6 smaller meals kind of grazing throughout the day. If you're one of the people that has to have 3 main meals, then you eat your protein, the largest part of your protein, at lunchtime. Because that way you have time to be able to process it, and then you have the rest of the evening. What I didn't talk about is that we have a bewitching hour. I don't know why we have it, but we do, between 2 and 4. Patients that seem to be on the LCIG, or the CLES as they call it now, is that they need to take a nap. They need to lay down and rest for at least a half an hour. And most of the people did not do that before, but I mandated it during the study. And what they found is that when they did lay down and rest for a half an hour, that they did have, the fatigue was gone, they were able to get going again, and it may have a combination of they just needed to rest and they needed the protein from the lunch to go out of their system. But I did encourage, and I have encouraged all my subjects, not my patients yet, but my subjects, to maintain the same program that they've been doing. The other thing that we found very interesting is that we tried at 6 o'clock in the morning with all of our subjects that they eat an orange. We tried grapefruit, orange juice, grapefruit juice, apple juice. Nothing was as effective as eating an orange to get that Cinemet going. Not sure why, there's no proof, but we know that every single one of our subjects, when they ate an orange before we put on the pump, they were much more effective. And so we should do our own little study on just the nutritional component of that, but protein does affect the Cinemet program that I'm on, and it does affect the absorption. So if you're eating pills or you're taking your pills, you're going through the gastric acid and it's competing with the protein, it does affect how it's going to be absorbed. That's my personal opinion.
Okay, so some of these are a little bit related, so I'm going to try to knock them out together. So one question was, can I take dopamine agonists and levodopa together? And the question is yes. There's a lot of patients, many of the patients in this room are on a combination of dopamine agonists and levodopa, so there's no problem with combining those, and there are clinical trials that have specifically looked at the combination of those medications. In some patients, it's a good idea, and in some patients, it may not be a good idea based on age and other issues, so it really is very specific to the patient. There was another question, when will Rytary be available in the clinic? It is available now. You are able to get this medication through the clinic and through pharmacies. Rytary is the medication that was discussed a little bit earlier. I think Dr. Jankovic covered it a little bit. It's a new long-acting form of Cinemet. It's basically really small beads instead of the current long-acting form of Cinemet, which is carbidopa, levodopa with a coating on it. It is very new. It's only been out, I think it's a couple of weeks now, and less than a month. So it's going to take a little bit of time to get a good idea of in practice how this is really going to work. But in general, people have noticed it's been a bit more challenging than they've realized with regard to making a switch to a long-acting medication like this. There are definitely going to be some patients who are not going to be able to do it, and it is definitely going to be a situation that may be very challenging. So the idea sounds great, a new formulation of long-acting Cinemet, so it does, in concept, it's a great idea, but it may be a lot more challenging, and I think that's going to be a discussion with your actual neurologist to try to implement that. And then there was one other quick question. Rytary, R-Y-T-A-R-Y. There was a question, when will doctors be telling insurance companies what will be prescribed instead of insurance companies telling doctors what will be prescribed? I would love to wait for when that will be happening also. All the issues that you all experience getting things approved through your insurance company, we're on the other side of that, fighting with the insurance companies to try to get things approved. I don't have a good answer for that, but I can say we definitely share your pain up here on the panel. There was a question about Cinemed has been on the market long enough to be out of patent restrictions, so why is the brand so expensive and generic is pushed by the drug companies, and drug companies don't support the brand. So in general, when you're the company that has put forth the medication, the same thing as if you go to the store to buy CVS brand bandages and versus Band-Aids, there's going to be a little bit of a price difference. There's a comment here, FDA only requires generic to meet 85% to 120%. So what this is referring to is if you have a medication that's on patent and it's approved, the bioavailability of any generic only has to fall within about 80 to 85% to 120% range of the original. So where this becomes a major problem is if you have epilepsy. So there are some patients who can be on one brand of generic epileptic and they get switched to another brand and suddenly they have breakthrough seizures. It doesn't tend to happen as much in patients with Parkinson's disease, but every once in a while you'll get a patient who's on one brand of generic that switches to another brand, because then you could potentially be going from the 80 to 85% up to the 120%, and you notice a difference. But in general, it tends not to be as much of a problem for movement disorders as it is for other types of diseases.
Okay. And tagging on the protein thing, somebody asked how many grams should I eat? It's not necessarily a particular number of grams. It's just that a heavy protein load will compete for absorption with the medicine. So truthfully, taking your medicine on an empty stomach or half an hour before your meals or 2 hours after makes it absorb more. But generally, we tell people take it with your food so you remember to take it and don't get an upset stomach. It's just if you're particularly sensitive to needing to absorb every bit of it, it can be more effective. So this question is, I have a sleeping problem. I go to sleep well and I wake up at 4 in the morning. I understand Parkinson's can cause this. What can I do? And commonly, if there's a specific time that you wake up every night at that time, there's a very good chance it relates to your medication wearing off and your body recognizing that. So sometimes we have to add a long-acting medication at bedtime to help you get through the night, or some people even will take a dose in the middle of the night. If it were less predictable that it's always 4 a.m., then sometimes it could be related to urinary tract issues, needing to use the bathroom. Sometimes it's related to sleep disorders that frequently wake people, or even anxiety. But when it's a predictable time, we always look to the duration of the medication impact.
So I'm going to talk about mood. So there's a bunch of questions I have on mood, actually, and I don't think it should take someone like Robin Williams passing away or killing himself and having Parkinson's disease to tell this audience that mood disorders are a big deal in Parkinson's disease and pretty much all Parkinsonism. So I think we know now that up to 40%, probably more than that, of patients with Parkinson's suffer from some sort of mood disorder, whether it's anxiety, whether it's depression, depressed mood, and there are other issues obviously as well. Psychosis, kind of borders in there, so as well as a complication for Parkinson's disease, and that can be part of the disease, part of dementia, can be part of the treatment as well. So it's a bit complicated to talk about how we treat it, but I will tell you really, first for all of us, I think, if we recognize someone who presents with depression or anxiety, and I'm so happy that all of you do the forms that we give you, and we're very, very appreciative that you do fill out the forms you come in. And one of the forms you fill out is two of them. One's called a BDI or Beck Depression Scale, and the other one's an anxiety scale. And we are starting to incorporate that in our clinics, so we're putting red flags on them if you really tell us you're suicidal, for instance. But the point is really, we should be asking you. If we're not asking you, make us ask you, please. This is an important issue, and all of us, I think, if we recognize depression, I find if we treat the depression first, that's really more important than treating the Parkinson's. If we don't treat the depression, we're not going to really make much headway with the Parkinson's symptoms, not only will we not treat the symptoms, you guys won't be able to do the exercises or want to do the exercises or therapies that are there. And the same goes with anxiety. So it's a complicated issue. There are multiple medications out there that are really good. There's a lot of antidepressants. They work for anxiety as well. There's not one good one. Someone asked about Wellbutrin or what's called mirtazapine. It's not the only one out there. There are a number of them. If one doesn't work, we should try another one. But they generally take about 4 to 8 weeks to really have effectiveness. So it does take some time. They're not like your carbidopa, levodopa, that you take it and you know right away that it works. You have to give it some time to really get in your system and change how the brain works. So this is something you work with us with, and we do have 2 on-staff psychiatrists, Dr. Herb Ward and Dr. Sarah Fayad, that are really wonderful, and they've worked with probably many of you as well, and we will be happy to refer you to them as well. They work in the center, they work with Parkinson's disease patients or Parkinsonism patients, and they're well familiar with the issues that challenge Parkinson's patients from bottom up, okay? So this is an important issue, and I'm really glad that someone brought it up, okay?
So I had 2 questions here. It says, how do we enroll in the PDBP or the PPMI or the UF studies if they don't have Parkinson's disease, they would like to be a participant? And so in most of our studies, we do have people who do not have Parkinson's disease also in the studies. So it's actually very valuable to have those people. Actually, it's actually harder for us to recruit people who don't have Parkinson's disease sometimes for our studies than people who do. So if you're interested, after we get done here, just find me and I can tell you how to contact me. If you're interested or you have a good memory, my email is vcourt, V-C-O-U-R-T, so vcourt @ufl.edu. You're welcome to send me an email, and I can get you set up. The second one was, how do I get instructions for the resistance training exercise? I think a good way to do it would be to talk to Meredith. That would be my #1 recommendation. The second one is, if you're interested and you don't go to Meredith to see her for some reason, you're welcome to email me, and I will email you the program, and you can take it to another physical therapist or an exercise trainer to help you get it set up. Okay?
That's a good segue into my last 2, and it asks, do you inform your inpatients regarding the UF Health and Shands Fitness and Wellness Center on 13th Street? Wouldn't this be a great resource for your patients? Absolutely. So when I sit down and talk to the patients, we go over all of the options. The Shands UF Health Wellness program is wonderful. They have trained exercise physiologists on the premises that will help you get on your machines, get off your machines. But one of the things that I consider, are you still driving? Can you afford it? Being on a fixed income can limit access to working out in some of the gyms around town. The other resource that I know a lot of you all partake in, the Senior Center has access to equipment at a very low rate, and they also have 2 ongoing exercise classes specifically for patients with Parkinson's. So there are a lot of resources in the community, and for me, instead of just telling everybody this is the best place to go, it's good to sit down and find out what's going to be the best place for you to go based on all of the different factors that are going on in your life.
Do you have any more?
Is there a metronome app for the phone? Absolutely. If you just go into the search query and type in metronome, there are probably about 12 free ones that'll pop up. And like I said, 80 beats per minute would be the cadence to try.
I have more. Yeah. Okay. We'll do just maybe 2 or 3 more, and then if you didn't have your question answered, you can grab one of us afterwards. We'd be happy to answer it. One of them here is a good question. It says, recently I've had to reduce my blood pressure medication because my doses. What should I do if this is because of my Parkinson's medication? So it's a good question. There are some of the Parkinson medications can lower the blood pressure. If it's a mild effect, you may be able to work with your primary doctor to be sure it's safe, and then you may be able to lower your blood pressure medication. The effect is not always that strong that you will come off or lower it, but be careful because sometimes your blood pressure pill is also being used for your heart or for some other reason. Parkinson's itself can affect part of our nervous system called our autonomic nervous system, and it's the part of us that regulates stuff, and it moves our guts, and it controls our temperature regulation, and it controls our blood pressure. And sometimes people can have a problem where their blood pressure goes super high and super low, all within hours, all within even less than hours, and that can be trickier to manage. But if it is your Parkinson medication, the first question is there an alternative? Because sometimes we can make changes in the medicine and have less of an impact on the blood pressure. And the other question is, do you just have to be on that? So sometimes it might be that there's no choice. You need that to function, in which case there has to be a balancing with the blood pressure medicine. I'll do this last one in front of me, and then if you have another one. And this is, what effect does general anesthesia have on Parkinson's disease? And it's a good question because we don't fully know the answer, but what we do know, first of all, there are some Parkinson medications like selegiline and rasagiline that may interact with certain anesthetics, and those would need to be held for a week before surgery, or your anesthesiologist would need to know you were on them. But anesthesia itself, we know that in some individuals who may be vulnerable, could potentially cause a setback. Sometimes it's a cognitive setback, meaning memory trouble, and sometimes it doesn't. Most often people don't notice any major changes, but because we've recognized that we sometimes see that, we've actually had our neuropsychologist, Kate Price, is very interested in this and actually will do detailed testing with people before they go through an elective surgery, and that might help them decide if their cognition is doing pretty well and they have a little bit of reserve, they might decide to take a risk on a surgery that's not necessary. Now, if you have a necessary surgery, you have to do it. There's no choice. But otherwise, we can do testing before and after, and it can help you make an informed decision. Did you have any more?
So I didn't mention that. There was one question about emotions going up and down. I guess if you have that, I didn't mention that one, but if you do have problems with laughing or crying, that's sort of inappropriate. In other words, you're laughing, where you may see like something that seems kind of innocuous, but your spouse or your loved one actually is laughing kind of inappropriately. Or, for instance, if they are crying uncontrollably, and it's, they may be telling you, I'm not really sad, I'm just crying because I can't help myself doing it. That's what we call a labile mood. There's another term that we often use called pseudobulbar affect. So this is another very trying symptom in Parkinson's, and it's typically not Parkinson's disease, but other atypical Parkinson's disorders. There is treatment for it. It's actually kind of we call cough syrup plus a quinine or quinidine type mixture, and there's a drug called Nuedexta that's out that can actually help. But generally speaking, we treat also with antidepressants. If this happens, let us know. There are ways to actually effectively treat it. I do have one more that I have one more actually too, and I'll address this as well. So people are asking about this alpha-synuclein protein. So I think you heard Dr. Jankovic this morning actually bring up that there are a couple of hallmarks to Parkinson's disease in the way we diagnose it. One, of course, is the loss of dopamine cells. And then at a microscopic level, we see accumulation of proteins in the brain. And this is actually fairly common in almost every degenerative disease that we see. Parkinson's disease, Alzheimer's disease, frontotemporal dementia, ALS. There's a very common sort of hallmark that we see is abnormal deposition of certain proteins. In Parkinson's disease, it's these Lewy bodies, and they contain a lot of protein, and that protein frequently is called alpha-synuclein. So someone asked me, what is it? Well, alpha-synuclein is actually a normal protein, just like in Alzheimer's disease. Amyloid is actually a normal protein in your brain. It's actually when it goes awry, either misfolds or starts to accumulate in an abnormal way. So we're really talking about normal proteins in your brain that basically either accumulate or they get tagged some way, or they basically start to act in a wrong way. And they accumulate and they get in the brain and they form these things called Lewy bodies. So you can imagine if a cell basically gets filled with a giant protein and it forms this large inclusion, it's not a good thing for your cells. Your cells don't work properly. And in fact, actually causes stress in the cells, and the cells begin to die. So there's a lot of research, our lab and many other labs around the country and even the world are actually trying to figure out what that cascade is, what makes alpha-synuclein aggregate and form these Lewy bodies. So there's a lot of work ongoing, and there is a good data now suggesting that synucleins, when it goes awry, it does cause degeneration. And so a lot of people are focusing on it. So you heard this morning there are New treatments potentially coming out, so antibody treatments, there may be other ways of going at it as well to target synuclein. And I think someone asked a really good question is like, so what if we have these treatments? When are they going to be good? Are they going to help me? So I think whoever asked that question was actually, it was a really good, brilliant question actually. So these treatments are going to be focusing on the cause of Parkinson's disease, and it may be true that once we see patients, largely we see patients, we say that by the time you're in our clinics, you've lost about 70–80% of your dopamine cells, and likely due to these proteins that accumulate in the brain. So we do need to identify patients earlier, and likely if we do have these new treatments, we're going to be targeting earlier patients. That's not to say that there may maybe be some benefits for patients who have Parkinson's disease now. But I think it's definitely, there's a lot of hope here for these new treatments. And we'll have to see how they actually turn out. But I think we're working towards these. I think you heard Dr. David Valancourt talk about biomarkers. We heard Dr. Jankovic talk about biomarkers, finding markers either in blood, fluid, tissue, or even using the brain imaging that Dr. Valancourt talked about to really diagnose patients early in that pre-symptomatic phase. That's where things are heading in the future. So it's really important that you all participate in our trials. We're learning a lot, and I agree that research that we're doing now may help future generations, but this is really key, and I think we want to help the future generation. And this is where the new treatments, and I hate to say the word cure is, but if we can stop the progression of disease, and a mild tremor is a heck of a lot better than needing a wheelchair. So I think there's a lot of hope, but that's where the importance of getting these markers. And maybe you can comment on your studies too, and how biomarkers are needed to.
Yeah, I mean, it's all about the future. It's about the way the future, different therapies are going to be tested in the future. And so it's difficult to say that it will help people now, because it probably won't. But it's going to help. It's going to help your kids. It's going to help your grandkids. It's going to help your cousin. And it's going to help people like that. It may help some of us on stage. Yeah.
So thank you so much for coming and for giving us great questions. And please let us know if there are topics you want to hear about next year. Every year we're trying to decide what we could have spoken about that you wanted to hear about. This is Amanda, and we're grateful that she organized this for us and found a facility and made it all happen. So please feel free to tell her or any of us topics you want to hear about or questions you didn't have answered, and we hope to see you again. Thanks for coming.
So I've got 3 things before we go. The first is I actually have a question, and I'm not a doctor, but this actually applies to the stuff that I do. And that is, what support is available to caregivers? And they're talking about a stage where Parkinson's patients are still active, but they're dealing with Parkinson's and side effects of levodopa. So if you are a caregiver and you need help, the best thing you can do is work with your care team for your husband or wife. There's social workers that are able to help with people coming into the home if you need, even just sometimes just helping with things around the house. But also, like for the support groups that are in the area, more support groups are also realizing that the caregivers need support just as much as the people with Parkinson's. And I know, like in the Gainesville group, we split off into caregivers and people with Parkinson's, because both parts need to vent and both parts need support, and I see that happening more often in support groups. If your local area does not have a caregiver support group, maybe it's time that it needs to. So, and then also there's a lot of resources online and a lot of online communities that can be there, and just to have that friendly, I want to say voice, but even just a friendly text, to have somebody say, I know how you feel, and have that person there with you, so that you can bring out your questions to them or to us and have some responses and some answers. But don't let the caregiver strain get you down, because it happens to us all. So the second thing that we have is I have a small presentation, and that is because the Art for Life program, every time Dr. Malati has a baby, loves to give, they do a wonderful job on art. Kathy Castle, where are you at? There you are. Hi. So the Art for Life program has a present for Dr. Malati. Malati. We were so happy to have her come back after her maternity leave, and you get a quilt. You know, you're getting stuff. They would like to give this to her real quick, and so they've made this, and or Kathy, and I know Kathy was.
I would like to recognize some of the other participants, Pat, Tom.
If you're stand up, if you're part of this beautiful Art for Life program, and artists, thank you guys so much.
This quilt was made in some manner because we didn't have a volunteer to lead the class, and I taught some of the men about how to use mathematics in making squares.
And for her older daughter, she has a big sister pillow.
So thank you so much. So what this is, we have a lot of programs that we probably should have mentioned, including the art group that meets once a week. They don't necessarily meet to talk about Parkinson's, but they happen to have Parkinson's, and they do art-related things together and just have some nice time together and discover a lot of creativity. And we also have a dance group, people that dance with Parkinson's and singing with Parkinson's, and an exercise class. So these are great things. One thing that everybody wants to know, what can I do to make my future better? And what we do know, there's a lot we don't know, but what we do know is that people that stay physically, cognitively, and socially active just do better. And that relates to normal aging, and it relates to Parkinson's. But I'm so touched and grateful, and thanks again, everybody, for coming.
Thank you.
Please fill out your feedback questionnaires. I've got red box lids at this exit and at that exit. And thank you so much for coming to the symposium this year. Also, if you want to watch any of these again, they will be available on our YouTube channel. I think are they this time, or are they, when they'll be available, Chuck? We'll go with the beginning of June. They'll definitely be there by the beginning of June. Just give them time for some editing. So thank you guys so much. Have a great day and a great weekend. Thank you guys.